So it was scheduled for a meeting. It's automatically gone into a meeting. You got it? Hey? Oh.
Yeah, and then I can just load it here. Gregor.
Sorry.
Okay. So, okay, I got
a C drive or
yeah,
a
C. I'll just and show. Yeah. Okay. And allow.
Still showing.
Sorry. Okay, 1 second. There you go. That's your thing. And where is it?
So, talks current.
Talks. Sorry. Okay. Talks.
And then there's a whole folder.
Okay.
This one, AIM.
Okay. What I'm gonna do is it's on Friday. Is it 2 talks?
There's 1 talk today and 2 tomorrow. Thanks, Raj.
Okay. So sorry. you got the raw deal actually, but it's because you're multi-talented.
Multi-talented, hardly.
It's good. Thanks for coming, Gregor.
No, that's all right.
So we still got another, I guess, 45 minutes to go. So
Fine.
So what I'll do is I'll try to bring one of the talks on Friday and the other one tomorrow.
So the trouble, they're linked to the videos in the folder.
So we'll just. Oh, okay. So you wanna just
leave the folder there.
Yeah,
it's probably easiest. I'll just run it out of the folder.
I'll try to see if it's playing.
Yeah.
So I'll need Ponchi and Amos.
Hello.
Yeah. Hey, Gerald.
Hey, hello.
Yeah. Gerald's our fellow.
Hello.
So this
Nice to
is
meet you.
Dr. Brown or Professor Brown. Okay, so that's there. Do you want me to check?
Yeah. So small bowel update.
Okay. Want me to play it?
There's only one video in this one, right down the end. There. It's really just running while there's questions. Should just be.
You play it? Oh.
No, that's not it.
Slideshow. No access to media. What do we do?
Do I need to relink it?
Can you relink it perhaps?
Yeah. It's sitting there, the video. Where is it? It's right down the end. Yeah.
Okay, take that out.
Yeah.
Okay, just cut. And insert media. Video from file.
That should work.
Okay.
It was in that same folder.
Okay. So it's in final. It's not in final
No,
slides.
that's not mine.
Friday. Yeah, it's here.
Oh, right.
Okay.
That one. And then it's...
This one?
No. Oh, no, that's another one. I forgot about that. It's... DBE. Yeah, that one is for there. And then there's another one.
Okay. So is that... Okay, let's see this. I'll just play it back. I normally like to just put it automatically.
Yeah, that's fine.
Let's see whether that's going to play. Yeah.
Better.
Yeah. Okay.
Just reposition it slightly higher in the frame.
Okay.
Just so it's sort of... That'll do. Yep.
That's all right?
Yep. And then isn't the other video higher up?
Save anyway. Okay.
Is the power spiral video.
Okay. And that's in the same...
It's in the same folder. Yeah.
Okay, so docs. Sorry, that's not there. Sorry. Okay, so it's there. So you need to put that in.
Yeah, that needs to be put in
presentation. Okay, so presentation will be on that, right? Small bowel up.
Yep.
Update. Okay. Raghu, I got
There
your
it
talk.
is.
I need to make sure the videos are
Yeah,
working.
yeah, I
we
checked.
just do.
Yeah.
Yeah, I checked. So that's
Just see,
working.
just see per chance. It might work.
Yeah.
Doesn't like my.
It's okay. It's all right. We can do that.
Yeah.
We can do it. So just cut and. Insert video file from file.
There's total PSE down the bottom there. Yeah.
This one.
Yeah.
Okay.
Okay. That'll be
Take it up or
just down a bit,
Down a bit.
just so we can see the title. Yeah, that should do.
okay. Playback
Automatic.
automatically. Okay. All right. Yep. Yep. So that's good. Just double check.
Yep.
Yeah. Okay. So that's good. Okay, and then we can do the rest.
The rest, yeah, the others tomorrow. We can do later.
Okay.
So I'll take that.
Okay. I'll just
Eject it.
eject it. Yeah, I'll just eject it. Should I rename it? Not erase. Eject. Should I rename that folder, or we should be able to see it? Yeah.
Or do you want to?
So it's just there.
Yeah.
Friday.
Right.
So
And then
this
we
are
can-
mine. This is
So
this.
tomorrow I'll need to reset
Yeah.
that because there's more videos.
Yeah.
For the,
Okay. Should I rename that to Greco?
yeah. If you just put.
Greco. Okay.
Okay.
Very good. Okay. Thank you.
No worries.
Yep. Raghu. You want to check?
No, I don't have it with me.
Yeah.
Should be all right.
Oh, what's happening?
No, that's all right. I just wanted to. You're right.
Okay. So it's KR.
KR
whatever-
final.
Yeah.
Yeah.
So I just put it there.
Yeah.
You want to check it?
Yeah. I'll just check the videos alone.
Disappear for a while and come back for 3 o'clock. And I give him. Now, do you want just to show histology or only to bring up comments and
Test, test. Hello, hello. Testing.
unless it's being asked, right? That we won't have the time, right? And so, yes. Okay. Yeah.
after we introduce the CEO.
Yeah.
Hello. Welcome all. Thank you for making time to come today on a busy Friday. So we'll officially start the 9th Advanced Imaging and Therapeutic Masterclass. So thank you for taking the time to be with us today. So I'd like to start off with this quote I sort of worked out over the last 24 hours. So the main intent of this workshop is to actually answer this question: what do we do with what we see? All right, so that's going to kind of be the theme of the entire workshop over the next 2 days. So try to think about that as we're working through all of the cases and the presentations over the next 48 hours. So I'd like to start off first with that concept in mind. And of course, the title of the conference is Practical Everyday Endoscopic Practice, so from diagnosis to treatment. We'll try to all learn the latest in mucosal imaging with an emphasis on improving diagnostic ability to detect, characterize, and treat esophageal, gastric, duodenal, and colorectal lesions. So then how and what to do with what we see with this information we gain. So there'll be a series of didactic lectures, videos, image presentations, MDT-like sessions, tandem talks, and debates without any fights, of course. And we also have included a hands-on component this year. So we've worked quite hard with that over the last 24 hours. So we've got 8 stations in the endoscopy suite with 24 participants, half of whom are nurses and the other half are medics. All those 24 seats have been taken up, but if you are interested, please feel free to come by after the workshop tomorrow to have a look at all of the stations. And there are some very interesting things there which we have obtained from overseas, especially from Japan. So the course is quite interactive. We hope to have lots of interaction amongst the participants and with the chairs and, of course, the speakers as well. So if you look at your program books right at the end or at the back, there'll be a link to a QR code, which will be linked to a system called Slido. So what we'd like to do is, if you've got any questions, you can either send it through that link, or you can simply ask for a mic. There'll be a roving mic around, and you can just ask the question directly to the speaker of the session. So we'll try to maintain time as we do this. So hopefully by the end of all of this, you'll be able to gain some knowledge and hopefully take this back to your respective units. If you work here, obviously take it back here. And hopefully we can improve patient care. So we have a stellar cast of local and international faculty. We've got 2 of them, Professor Amol Bapaye and Professor Honchi Yip, who've come from India and Hong Kong respectively. These guys are master endoscopists, I would tell you that. I've seen them in action personally, and they're just fantastic teachers as well as proceduralists. So thank you, Amol and Honchi, for coming. And then we do have a host of national faculty who have taken the time to come today on a working day. So that includes Dr. Perveen Aslam, who's from the Canberra Hospital. Perveen is over there. Thank you for coming, Perveen. Dr. George Balalis, who we all know locally, sitting next to Liz. Thanks, George. Dr. Cameron Bell, who is next to Liz and between Gregor. Cameron's very much pivotal with the colorectal cancer screening strategies for the country. And we've got Associate Professor Gregor Brown, who's sitting next to him, he said I've given him 3 talks, so I told him that he's multi-talented, that's why. So Gregor will also speak on the small bowel in addition to colonoscopic techniques. And then we have our stellar cast from the Royal Perth Hospital, Dr. Niroshan Mohanvela. Niroshan is an expert in third space endoscopy, so thanks for coming, Niroshan. Not to forget my boss, Dr. Liz Murphy, who's the head of colorectal surgery and, of course, the divisional director for surgery here at the Lyle McEwen and the Modbury Hospital. So thanks, Liz, for taking time to come as well. We've got Professor Krish Raghunath, my mentor, who's now based in Perth, and Krish will be speaking to us about Barrett's. Thanks, Krish, for coming. And we've got two of our very close pathologists who probably are gastroenterologists now as well. So Sarah Saxon, thanks for coming, Sarah, and Associate Professor Andrew Ruskovich, who's Sarah has asked to work downstairs while she presents today, but he'll come back upstairs. And Sean Shin and Ned Young, who are two of our up-and-coming gastroenterologists who are here today and will be speaking to us later on tomorrow, I think. So thanks for coming as well, Sean and Ned. We've got all our local chairs around as well, who you will see as the day passes by, today and tomorrow. And of course, finally, just before I hand over to our CEO, Karen, I would like to thank the Nalan executive for the massive support for this workshop, as well as Liz from the Division of Surgery and all of the staff with the division. Our sponsors have been pivotal for this workshop. So that includes Olympus Australia and Olympus Asia Pacific, including especially Kate, Joanne, and Eunice, as well as the AV team over there with Scott and Brian. So I'll truly look forward to an educational day, and I'm going to hand this now to Karen Puvujal, who will formally open the proceedings. So thank you again. Thanks, Karen.
Okay, can you hear me okay? I'd like to acknowledge that we're actually meeting on Kaurna lands today here at Lyle Mac, and acknowledge the other lands for those participants who are not here with us in person. Good afternoon. It's an absolute pleasure to welcome you to Lyle McEwen today for the 9th Advanced Imaging and Therapeutic Masterclass. Whether you're joining us in person, connecting us virtually, or joining us tomorrow, we're delighted to have you with us here. We're really proud to host this event, and it's really important for us to bring a diverse range of people together because it's all about collaboration. Collaboration and shared learning, particularly for the advanced practical endoscopic practices. That shared commitment to excellence, innovation, and most importantly, improving health outcomes for the patients that enter our care. Endoscopy is a rapidly evolving field, and this masterclass is designed to address some of the most pressing and exciting aspects of clinical practice. Advances in technology, techniques, and multi-D collaborations are transforming how we diagnose and treat and prevent disease. Here at Nalan, we've continued to grow. That's one of our values, and that's about providing exceptional service and education of the next generation of specialists coming through. We've got 2 PhD students who'll be completing their thesis in the next few months. Over the last decade, Nalan's research activities expanded significantly, with more than 200 publications appearing in international journals. And this is a new fact that I actually learnt. Apparently, we published a book on advanced endoscopy, which has sold more than 70,000 copies worldwide, which is amazing. This is a testament to the expertise and knowledge within our team. We've been recognised as one of the most advanced units in Australia and continue to attract trainees from all over the world. To date, we've had 15 international endoscopy fellows from across the globe, and we continue to grow. All of this is made possible thanks to our amazing team, who are pivotal in providing the service that they have provided for many years and have gone beyond the call of duty. Events like this masterclass are critical, not just in sharing knowledge, but also challenging thinking, redefining skills, and strengthening partnerships. Over the next 2 days, you'll have the opportunity to delve into case studies, highlight real-world applications of endoscopic techniques, bridging the gap between theory and practice, so the knowledge gained here can be translated directly into your clinical practice. I'd like to acknowledge the hard work of the national and international faculty who are generously sharing their expertise and research to make this event possible. To our participants, thank you for investing your time, energy and curiosity. I encourage you to take full advantage of this opportunity to learn from one another across all disciplines and borders. This masterclass promises to spark great discussions, and thank you again for joining us here today, and thank you for allowing me to do this opening address.
Thanks, Karen, and thanks, Giuseppe. Giuseppe is our COO, so thanks, Giuseppe, for coming. Thank you. All right.
Okay. Without much further ado, I'd like to invite the three chairpersons for the first session to come onto the stage. Firstly, Dr. Hamish Philpott, who is a consultant gastroenterologist who practices at the Lau McEwen and Montbury hospitals with a subspecialty interest in esophageal diseases, colorectal cancer screening and prevention, and inflammatory bowel diseases. Dr. Hamish, please. Secondly, Dr. Harsh Kanhari. Prof. Harsh Kanhari is the head of the upper GI surgery at the Royal Adelaide Hospital and a senior consultant surgeon in the upper GI and hepatobiliary and pancreatic surgery units at the Queen Elizabeth Hospital. And lastly, Prof. Sarah Thompson, who is an upper GI surgeon as well as the head at the Flinders University. Prof. Sarah, please.
Right, so I think before we even start, we're running late, so we should get started. I'll kickstart the session with how to evaluate the esophagus, and hope to sort of complete this in the next few minutes. So this is the outline of my talk, which will include pathology guidelines and some cases. I'll be putting lots of cases, benign versus pre-malignant lesions. I'm not going to cover Barrett's esophagus because Professor Raghunath will cover that and hopefully touch about something on reflux as well. So if we have time, we will just touch a little bit on submucosal lesions, and Professor Bapaye and Yip will be touching on that later on in the session after the tea session. So I'll discuss some guidelines and then go on to cases of benign versus pre-malignant. This is a joint statement, position statement, which was devised by Professor Raghunath and team with regards to the esophagus only. So I'm not going to put anything on the stomach, but for an upper GI endoscopy, if squamous neoplasia is suspected, an assessment with image-enhanced endoscopy is recommended. In patients with dysphagia, you should take biopsies from 2 different regions of the esophagus to rule out EOE. The presence of an inlet patch, its distance from the incisors and the size should be documented. Routine biopsies of the inlet patch is not necessary. And if there's a hiatus hernia, you have to measure it and it should be reported and documented. So this is all part of national guidelines and mandatory. This is just a WEO consensus committee guideline which we worked on over the last few years. I happen to be part of this initiative, which included a lot of people from overseas. So this is an endoscopy, and you can obviously see vocal cords and the right and left piriform fossa, which we actually tend to ignore as we are going down. So it's important to sometimes look at these so you can actually find lesions as well. So you can see how the proceduralist is fairly relaxed as the scope is going down. And within the esophagus itself, it's worthwhile to ensure that you insufflate the esophagus properly. Understand where you are. If necessary, you can see that water is pooling on the left lateral wall, which means that that's where obviously the patient's on the left lateral position, and the right wall is just at the 12 o'clock position. As the scope is advanced, you would notice that we have the GOJ, and it's important to take a nice still image of the GOJ. I've cut short this video so you can actually see retroflexion and withdrawal, which may be necessary with a different imaging modality. So in this instance, we're using narrowband imaging to try to see if we can detect any potential pathology. So this is one way of doing a good thorough look of the esophagus. I'll come up with some cases and just show you some examples of cases. So this looks like a whitish patch. And obviously the patch extends more proximally. there's a lot of, oh, okay. Yeah, that's better. And you can actually see that there's some sort of whitish discoloration there, and that carries on quite proximally as well. So sometimes it's a problem as to understand what is this whitish patch. So in this instance, we took some biopsies. It came back as epidermoid metaplasia. And you can see a nice histological slide there to show that part of the area is squamous epithelium, as you can see there, and part of it is skin. So or mimicking skin, that is. So this is a pre-malignant condition and has to be removed. This patient was in their 50s, and we took it off using an endoscopic mucosal resection technique. Sometimes you'll find different type of whitish patches, as you can see there as well. So Candida is a common cause of infections, and it can be due to impaired immunity, stasis, and obviously diabetes. You get these patchy white creamy spots, small plaques, and friable mucosa. So you have to think of different situations as well, but don't forget that sometimes these lesions can mimic squamous cell cancer. So in this instance, you can actually see that there's what's called as IPCLs, intrapapillary capillary loops, and after putting some iodine on the surface, you can see that there's discoloration of the squamous patch compared to the brownish discoloration which iodine tends to be absorbed in patients with normal mucosa. This is another case of a small lesion which looks basically like a squamous papilloma. They're rare and small and solitary and found incidentally. There's a small risk of malignant transformation, especially if the patient has multiple lesions, dysplasia, or strong smoking and alcohol history. In this instance, the patient had an esophageal varix underneath the papilloma. So what we had to do is we had to carefully remove it using a band ligation technique, and then later on band the varix underneath it with another band, and the patient did fairly well. Sometimes, this is my only Barrett slide, sometimes you have patients who come in with what appears to be like reflux, but you have to look carefully. In this instance, this was actually a high-grade dysplastic lesion which is happened to be in one of the Barrett segment. The patient had to come back for a resection, but when the patient came back, that lesion appeared to have disappeared because this is something called a subsquamous extension. So this is before, this is after. We then managed to locate the lesion on the second go and then resect it, and we found that the lesion actually had dysplasia underneath neosquamous epithelialization. So sometimes dysplasia can be below the Barrett segment in the squamous epithelium. I won't go through this in detail, but I'll probably ask Hamish later on to give a few comments on EOE, which we increasingly are seeing more commonly. And you should understand the ERAF score, the endoscopic reference score, with regards to edema, rings, exudates, furrows, and strictures. This is just another example of whitish type patches, but the actual pathology is not below, but it's in this sort of area where you can see what's called as IPCLs. This with a bit of Lugol's, and you find something called the pink color sign, which is a nice prelude to squamous cell cancers. So we need to detect them, and sometimes they're very subtle. They can be flat or sometimes slightly depressed, but they do appear to be reddish in discoloration. So this is just an example of a case which was referred for resection. But as we look closer, we find that with Lugol's iodine, there's a lot of flat areas, and the extension is quite extensive. So it pays to have a good look, a good careful look if you're looking at a lesion to try to identify what's happening. Obviously, this is an extensive SCC, and it's best dealt with either surgically or with radiotherapy. The pink color sign is something you can see as well. So as Lugol's sort of eases out, you can see that the discoloration turns to pink. Like this, and you have to wait for about 1 or 2 minutes. But just be careful that Lugol's iodine can lead to quite bad aspiration pneumonitis. So you want to be very careful as you spray Lugol's into the esophagus. Narrowband imaging, I won't go into detail, but just to say that it's similar to Lugol's as well with regards to how it performs. So it may be a good modality to use. And we've got various sort of other modalities as well now in the market, electronic chromoendoscopy, as advised by the ANZ consortium. So you have to use any of this before you spray Lugol's because you can't really see the epithelium. So there are branching vessels and what's called as IPCLs, or intrapapillary capillary loops. These IPCLs will give us an answer, will teach us, will tell us, will inform us as to what the lesion is. So if you've got these closed loops like that, so mind you, these are highly magnified images, they'll be in keeping with a squamous cell cancer which has basically gone to the epithelium or lamina propria but not beyond. But when the loops start opening up like that, you'll find that this is in keeping with what the Japanese describe as B2 type lesion, which means that it's gone to the muscularis mucosa or submucosa. And obviously this is an overt cancer. As you can see, the vessels are quite prominent. So M1 or M2 or loop-like formation has got a 0% risk of lymph node mets. When it's M3 or SM1, or when the loop starts opening up, the risk is up to 20%. However, if there's highly dilated abnormal vessels, then you know that this is way beyond what can be treated endoscopically. All right, so these are just some examples. Looks like reflux, but as you go closer, you can actually see that the IPCLs are sort of a closed loop-like pattern. This was subsequently sprayed with Lugol's and resected. This is the ESG guideline, which Raghu will also show us later on. But for the squamous lesions, you can perhaps subject B1 and B2 lesions to an endoscopic resection technique. So this is just some examples. Again, may not look very much, may look like reflux, but actually if you look closer, the IPCLs are closed loops. That's in keeping with a lesion which is deemed as B1, meaning it's in the epithelium or lamina propria, and we subsequently removed it using an ESD technique. However, if you see lesions like that, this looks like a B1 lesion. Some of it looks like B2, where the loops are open, but some of it looks like B3, where it's neovascularization. So you're not going to touch this endoscopically. This cannot be submitted to an endoscopic resection. Another example, this lady was quite young, and we looked at the lesion further, and we found that perhaps it's a B2. It's quite arbitrary whether this could be B3 as well. There's a bit of debris on the surface. We lifted the lesion quite well and removed it endoscopically, and it came back to be in that sort of realm of a B2 lesion, which means that the risk of lymph node mets were up to 20%, and she subsequently had an esophagectomy. This is an example of a patient who is not fit for surgery or chemoradiotherapy. There's some B2 areas here. So we removed this in a circumferential manner, making tunnels on one side and the other, and then sort of connecting both of them and putting it on a syringe like that. So this was about a 5 centimeter lesion. Obviously, they'll develop strictures, sometimes pinhole type, which we dilated. And on the third dilatation, we found this. So it's up to your interpretation whether that's a bit of clot or there's something beyond. We didn't want to wait for that. So we inserted a stent which was fixated with overstitch. On bringing the patient back, the patient did really well actually. There was granulation tissue on the proximal side, so we had to carefully remove the stitch, put another stent to try to sort of necrose the area, and then remove both stents last week. Fortunately, it's done really well. So these sort of lesions can be addressed endoscopically, but they also are associated with a lot of risk. This is just another case of a circumferential lesion which had got B1 and B2 patterns, which we resected. On bringing the patient back, in SCCs, it's important to look at sort of metachronous areas. So if you can see something in the foreground, it's great, because that was actually another SCC which had a B1 to B2 pattern, which was subsequently removed using an ESD technique. Some other cases of circumferential areas which can be addressed. This patient had varix underneath that, so we removed it and then we banded the varix. So that's a band being put on the varix over there. And the patient has done fairly well. This 4 weeks later, where it's slowly healing. And unfortunately for the patient, he has continued to drink, and about 12 months later, he's now encephalopathic. So we have to look into that as well. But this has more or less sorted the patient's problem out. So I won't touch on subepithelial lesions, just to say there's a host of different pathologies, and Amol and Honchi, Amol will be touching on the esophageal side. Sometimes these lesions are benign, but sometimes we just don't know. In this case, a lesion was straddling the GOJ, which was removed using the ESD technique after an EUS evaluation was done. So finally, in evaluating the esophagus, I think it's important to identify the landmarks. Take your time, perhaps using one modality of imaging in and another modality out. I think that's quite helpful. You look at the esophagus twice with 2 different modalities. Use Lugol's iodine if you're unsure, especially for squamous cell cancers. If there's a suspicion, like in this case here, you can see the discoloration and then the pink color sign coming up later on. Recognize and characterize pathology. Obviously, as I mentioned, using advanced imaging tools at your disposal, which is kind of available in most units in the state. So if you're interested, Karen was talking about this Atlas of Advanced Endoscopy. You can have a look. We don't get any proceedings from this, but I think it's quite useful to use it and understand things. This is our workshop here today. So thank you very much.
Thanks, Raj. I think we'll take questions at the end in the interest of time. Or do you?
We can take a few questions for about 3 minutes, perhaps. Is there anything on Slido, Gerald? Okay.
I have
Sarah?
My question to you, you said right at the beginning that you should document the presence of an inlet patch. I never document it. I don't biopsy it. Why do you think you need to document it?
I think there have been some data to suggest that by documenting it, which is about 10% in the general population, there's some sort of backward understanding that we would have evaluated the esophagus well. All right, so that's one thing. There's no need to biopsy it. None of us do. I tend to find them on my way out, actually, because as you get in, you want to just go beyond the sphincter and get into at least the mid-esophagus. So I think it's a good sort of quality indicator to suggest that one had a good look of the esophagus, either on the way in or out. I'm interested to hear of Hamish's opinion on EOE and what should we do if we have a patient with suspicion of dysphagia. Do you biopsy all dysphagic esophagus?
Thanks, Raj. I personally do biopsy everyone with significant dysphagia, because the miss rate, if you compare histology versus endoscopic inspection alone, will be about 10 to 15%. So you'll think the esophagus is normal, and then you'll miss 15% of patients with EOE. So I tend to do that, unless, of course, you find some other explanation for dysphagia, which is clear-cut. But I'll be taking biopsies of the lower and middle esophagus.
And how many biopsies?
So at least 6 specimens of tissue. Personally, what I do is obtain 4 specimens in the lower esophagus and 4 in the mid-esophagus.
And for the lower, do you take it proximal to the GOJ?
Yeah, I'll start several centimetres above the gastroesophageal junction, and that's actually the peak area of activity of EOE is actually in the distal esophagus, which I think is important, because historically you would previously get reports from histologists histopathologists saying, well, you know, the lower esophagus is active, the middle esophagus is inactive, and perhaps it's gastroesophageal reflux disease. But the finding of 15 or more eosinophils in the lower esophagus is very indicative of EOE.
So 5 centimeters proximal to
5
the
centimetres proximal and another 5 centimetres above.
Above, okay.
Sorry, just one additional question. And I'm not sure how many trainees are here, but you said to document the presence of a hiatus hernia. It drives me nuts as an upper GI surgeon that people don't document it or describe it very well.
Yep.
So can you just outline what you think is minimum to describe what you see when you retroflex?
So I hope Professor Raghunath will you be covering that, Raghu, by any chance, in your talk?
Not really, I will be focusing on that, but
Yeah. Yeah, so basically a few pointers. The first is to identify where the esophagus sort of ends and where the stomach begins. So that's the gastric folds. So if we can identify that, so that will be one area where we would want to document how far is it from the incisors. And next will be the diaphragmatic pinch. So then you put 2 and 2 together and minus each other off, and that's how big or small the hiatus is. I think it also depends, obviously, on the level of insufflation. And that's one very common problem. So minimal to moderate insufflation is probably preferable. But in order to open up the GOJ, it's important to insufflate the stomach fully and always retroflex, if possible, within the hiatus. I do that commonly. Sometimes scopes are not good enough to kind of retroflex, but I think there are times when we do miss smallish lesions along the cardia.
Any questions from the audience? No. Thanks, Raj.
Okay, thank you. Thank you.
We'll have you back on the podium in a minute again. Thank you. It's my pleasure to welcome Professor Krish Raghunath. Krish is an adjunct clinical professor at Curtin University Medical School in Perth. He's obviously got very significant clinical and research interests in Barrett's and endoscopic therapy of early GI neoplasia. He's extensively published and co-authored over 150 peer-reviewed articles. He's going to tell us about Barrett's esophagus, how to find it, how to characterize it, and how to treat dysplasia.
Thank you very much for your generous introduction, and thanks, Raj, for inviting me again here. And thanks for Olympus for sponsoring this event. These are my disclosures. So this was exactly 10 years ago, Raj. I looked at the date. It was 3rd February 2018. You can see a lot of us look young. You can see Brad sitting there, Andrew, William, Tam. But the only person who still stays young is you. Good. Thank you for the invite. Okay, let's move on. Barrett's esophagus. Yeah, that's right. Barrett's esophagus is challenging. It can be daunting, and it is. If you delve into it, there's a lot to it, and a lot of us have done a thesis on Barrett's esophagus. So the first challenge is identification and assessment of dysplasia. As you know, it's a pre-malignant condition. We want to find the early cancers so that it can be treated effectively. How would you describe this? So essentially, you can have a non-visible dysplastic areas. It can be subtly visible, which will be visible to people who have seen these things before, and it will be obviously visible for anyone using any gastroscopes. So the key here is how to make the not seen one seen. And that's where advanced imaging comes, and that's where the experience comes, and that's where a systematic observation comes. So this is a good paper by Jürgen Pohl when he was in Wiesbaden, in 2010. They went through the database in Wiesbaden, over 700 patients, and came up saying that only about 3.3% were macroscopically occult neoplasm. Obviously, there are obvious ones, subtle ones, and if you are doing a high-quality examination, you should be able to identify dysplasia in 95% of the patients, and there shouldn't be more than 5% which has dysplasia and random biopsies. I think it still stays good, and it would be one of the key performance indicators for us. Obviously, you need a clean esophagus to do it. I'm not going to go through all these things. These are all minimum standards, how you do an endoscopy. And also the kit, what you use is important as well. We have moved on from high definition to ultra high definition, which is now 4K, and almost all the latest equipments from the manufacturers are 4K now, which we should be using. And what is the evidence behind it? There's not big evidence behind using high definition, standard definition, and ultra high definition. This is one of the data which we published a few years ago with a few of my PhD students at the time, where in Nottingham we have 2 hospitals. One is Queen's Medical Centre, the other one City Hospital. And during the study period at the City Hospital, we had the standard definition compared to at Queen's Medical Centre, we had the high definition. When you looked into it, there is a subtle improvement when you use high definition endoscopy diagnosing dysplasia. So I think there is some value in using high definition, and that should be the standard nowadays. Next question is where to look for. So you have limited time. You want to maximize your endoscopy. If you're going to be finding something, most often you're going to be finding between 2 to 5 o'clock. Several studies have been done. They've all shown that it's between the 2 to 5 o'clock position or 6 o'clock position where you'll be seeing. It may be related to the reflex head, the motility, whatever it is, but that's where you see most of the lesions. And one of the studies had shown that it's more commonly seen in the proximal segment. But I think focusing on the right side of your screen makes a big difference. That's where most dysplasias occur. How long to look for? This is one of the first studies from Pratik's group from the US, which was an imaging study, and this was a subgroup analysis, which they realized that if you spend more than a minute per centimeter, then your dysplasia detection rate goes up. Few studies have followed on, and this one, what we did between Nottingham and Cambridge a few years ago, showed that in all comers, you increase your dysplasia detection by 10%, and in a longer segment, you increase it by 25%. So the incremental time, procedural time, was 0.9 minutes, which is essentially 1 minute per centimeter. So I think that should be the sort of a minimum standards what we should be using. Next, inflation and deflation. This is another very important aspect of your endoscopy, where typically again between 12 to 3 o'clock, and this is not inflating very well. If you're inflating too hard, you can flatten it out, you might miss these lesions, and if you collapse it, then you'll miss it. So these are subtle things which you observe as you go along when you are inserting the scope in. Identifying and examining the gastroesophageal lesions is again challenging. Most of the Barrett's early cancers are around this area, which is missed, if you look into the missed cancers and upper GI cancers. So using a distal transparent cap helps you to stabilize the scope, and doing a retroversion, like Raj said, into the hiatus hernia is the key. There's no point in looking at the GOJ from the antrum. So you need to get your scope well retroflexed and pull it back in. And this examination here, I have summarized almost everything in Barrett's, how you do. First of all, identifying the diaphragmatic pinch, which is about 43 centimeters there. And then you can see the longitudinal folds of the stomach ending. Any mucus and things needs to be sucked off. A transparent cap is there. And that is the GO junction, which is 40 centimeters, which means that there is a 3 centimeter hiatus hernia. And then the scope is gently pulled along, trying to keep the lumen in the center. I don't know, some of you might have noticed a lesion there, but we'll come to it later. As we keep getting the scope back, then you start to measure the circumferential extent, which you will see soon. And that's a Prague criteria on the left, where you can see the cartoon there. And now we have got the hiatus hernia followed by the circumferential extent, which is about 36 centimeters in this particular patient. And then the maximum extent is 34. So that makes this Barrett's esophagus classification here as Prague C4M6. Once you have done that, what you do is you go back in and do a retroflexion, because that's where you can miss out subtle lesions. In this particular case, you can see retroflexion is being done, and there is a subtle nodular lesion up here. So it's important to do a thorough examination like that. It takes a few minutes to do it, but if you do it, you can get it right. And then you can use some advanced imaging like narrowband imaging and so on. So this is the Paris 1S lesion, 12 millimeters at the GOJ. This video, I'm just going to demonstrate a little bit of how you use advanced imaging here. Nowadays, with the clock, you can put the clock on and it will measure the time what you are doing, like your colonoscopy with dwell time. And there's already a subtle lesion which I picked up. You can use a TXI, which really gives you good contrast, and then followed on by narrowband imaging. And what you're seeing here is a subtle lesion, again around 12 to 3 o'clock position. You can see the vascular changes nicely with one-step zoom. That's more than enough now. And then there's pit pattern destruction as well. So there's both pit pattern destruction as well as vascular changes, which is quite classic for an intramucosal carcinoma here. So this is a good example of how you would do a systematic examination, a gentle pullback, and then use advanced imaging as well. So we call this as a trimodal imaging or multimodal imaging, where you use a white light and then you use enhancement. In this particular case, it is a TXI, and you can see this is a dysplastic tongue. And one of the things what you notice is that there is a very subtle nodular area there. And once you pick up things like that, then you can go in for one-step zoom. That's more than enough. With the current scope, it's nearly 100 times magnification, and you can quite clearly see the dysplastic area. So what I want to appreciate here, there are a lot of classifications, the Bing classification. There are other classification systems with BLI and OE, but the simple thing what you need to know is how is the vascularity there and how is the pit patterns. So you can see this vascularity is all quite disturbed compared to the normal vasculature around here, and the pit patterns are gone. So that's quite a typical area where you find early cancer, and that was an intramucosal carcinoma. So this is a good example of how you use white light. First step is a contrast enhancement with TXI, and then you go into narrowband imaging to characterize the lesion. So detection and characterization. Next is something what we have been doing for a long time, acetic acid, which I think one of the first publications that we did from Nottingham was in 2005, long time ago, where you spray acetic acid on the esophagus, and then it gets you a white reaction like this, white reaction, and dysplastic areas are red, which loses the redness there. Pradeep's group showed that the time taken for it to lose the ester whitening correlates with the dysplasia grading. And quite a few studies have been done, especially the post-mortem group, and it is a very valid thing. So if you're not too comfortable using image enhancement, just throw in some vinegar and it should be good. And sensitivity is over 90%. This was a systematic review that we did a few years ago. So there are two options here. Either use acetic acid or use your enhancement techniques, which will be good. Now, the question about subsquamous, this is increasingly we are starting to see. Initially, we talked about it when post-ablation for PDT, which was first described, and then APC and RFA, but now we are seeing it even in treatment-naive patients. This is a classic example where it looks like it's a short tongue, but if you look at it carefully, you will see we're using the image enhancement in this particular case, BLI. There is a little bit of darkness below the squamous epithelium, and that is nearly 1 to 2 centimeters of submucosal extension. And this one's lesion has to be resected. Neurosurgeon did this one. You can see the nodal area on wide resection, and that's important to do it. What is the evidence behind it? Andrew's group from Melbourne did the study. It was Linda Yang's PhD as well, which I had the pleasure of examining. What she came up with was the dark brown areas on NBI, what you see in the squamous epithelium, and slightly nodal areas. The sensitivity and possibility value is not great, but this is what we have now. And I think this was using the 190 scopes, but if you use the X1 scopes, you can see it even more better. And I think this is a good way of detecting subtle submucosal extension of the Barrett's, and it is important because you can easily miss cancers. And Vani wrote a very good editorial on this paper. Finally, I'll summarize what I've said here. Systematic review, meta-analysis, and an umbrella systematic review all points towards image enhancement. And the ESGE suggests that you use either chromendoscopy, which is acetic acid, or virtual chromendoscopy, like narrowband imaging, what I showed you, which should be the standard when you're doing endoscopy. A few other quality indicators here are, your biopsy rate, the longer inspection time, propofol sedation. They're all something which need to be taken into account as well when you're doing Barrett surveillance. So in this cartoon, I'll just summarize saying that systematic observation, like what I said, and then selectively use image enhancement so that you can find this buggy here. Now let's move on to how we manage Barrett's esophagus. So the first thing to know is there a visible lesion or not? I would say more than 90 to 95% you should be able to see a visible lesion. If there's no visible lesion and you see high-grade dysplasia on 2 separate occasions, then you can consider ablation using radiofrequency ablation, which has got enough evidence now. If you see a visible lesion, then this needs an endoscopic resection because you don't want to be burying cancers doing ablation. And the technique of choice depends on the lesions, and we'll talk a little bit about it in the next few slides. The endoscopic resection is the next challenge, how you would do it and the technique you would use it. It also depends on the location and the technique what you use. The one on the left side there, you can simply resect with the band EMR, but something like this might need endoscopic submucosal dissection. Talking about the EMR, the multiband ligation EMR has been over 10-15 years now, and Nipsohenda first invented the kit from Cook, Duet, and now the other companies are manufacturing it as well. And this is the gold standard, and it has been tested over time. And here you can see it has been marked, and it's quite easy. Many people would be doing band ligations and a simple technique, and you can put in a band and then do a resection. You can do multiple areas, and you can do a wide resection, and it is quite safe as well. There are a few recent studies which have looked into over 1,000 patients who have had endoscopy resections and followed up, showing a perforation rate less than 1%, bleed 1 to 2%. So it's a pretty safe technique to do and quite effective as well to be doing, and quite widely practiced so as well. However, things are moving on now when we are taking more higher risk cancers, and it might not be the ideal choice for all patients. So this is where the thing comes about choosing wisely between EMR and ESD. Here you're seeing this is an EMR specimen from one of my patients. You can get up to 1.5 to, if you're lucky, you can get up to 2, but I would say 15 millimeters, you'll be able to get it. But if you want to go more than that, you need to go piecemeal. Is it good or bad is being questioned. If you do a ESD, you can get a nice big specimen, and Raj showed you can even do a circumferential resection, and it's almost like a surgical esophagectomy here, or endoscopic esophagectomy. Previously, the concept is that if you suspect submucosal invasion, then you go for ESD. Look at this data. This Sunil Gupta, led by Michael, they looked into Barrett's experts across 8 countries, and a few of us from Australia also did this. You can see that experts can differentiate between submucosal and mucosal cancer in less than 50% of the cases. So it's still a toss of a coin. You don't know which has got submucosal invasion. So that's where now these 2 papers are just hot online, published in Gut online, as well as an endoscopy, going in for universal ESD for large Barrett's cancers, 15 millimeters or more, showing that your en-bloc resection rate is higher, R0 resection rate is higher as well, and they had 2 years follow-up, showing reduced recurrence compared to EMR. Obviously, this is a retrospective historical comparative study, and you can see there's an overlap of authors as well in these 2 publications, Thomas Roche and Michael, so there might be some cases in both the studies, but the bottom line is that this is where it is moving. I think we need to see how it will transpire moving forward. The question is, if we start proposing this, then there can be a bit of a over treatment with more patients getting treated with a challenging procedure, and the expertise globally is not that much for ESD, and they can end up with complications. So you need to be a bit guarded and make sure that the endoscopists doing these procedures are good enough. The reason why I'm saying it is this nice good paper from Germany. They looked into the quality of the submucosal tissue, what you get with EMR and ESD. They're all quite good endoscopists from Germany, and very reliable pathologists as well, including Michael Wade. When they looked into the ESD and EMR specimens, 1/3 of both did not have enough submucosal tissue, which means that the issue is about the technique and the endoscopy skill. So this was between 3 centers. So there is a difference between the endoscopists having the amount of submucosal tissue when you do a ESD. So these are all fine details, nuances, which you need to know about the technique and the endoscopist doing it. So adopting ESD universally every endoscopist might not be the same. Finally, this quick slide about the ESG guidelines, which says that more than 2 centimeters. I think it's a bit too generous to say wait for 2 centimeters to do a ESD. I would even pull it down to 15 millimeters because more than 15 millimeters you might not be able to get en-bloc resection with the EMR. So that's something which may be revised in the future. In fact, we are even looking at our Australian guidelines, which hopefully will come out in the next year or so. The last one is about multifocal widespread dysplasia. The options here are surgery versus endoscopy. Obviously, if the patient is fit enough, then the patient can consider esophageectomy against circumferential ESD. It has got morbidity as well with circumferential ESD, which Raj showed in a few slides earlier on. So this publication is from Rob Bechara's group from Canada, one of the first publications. I know there are quite a few people, including ours and RPH, doing en-bloc resections using circumferential ESD. So this is on a small number of 11 patients who had circumferential ESD for multifocal high-grade dysplasia and intramucosal carcinoma. And you can see that the procedural time is anywhere 2 to 3 hours. So it's quite a long procedure. Patient needs to be on an anesthesia. And almost everyone will get a stricture at some point after the resection, which will need quite intensive management, dilatation, so on. We are still getting to grips with how we would manage them post-operatively. But interestingly, finally, about 2 patients had to go for surgery. So you need to weigh the balance of how far you're pushing endoscopic dissection and where you, because surgical advances are also there as well, minimally invasive surgery, the post-op care, etc. So those things are nuances which need to be taken into account. And these things could only happen in a center where there is expertise for both procedures and a good multidisciplinary team meeting should happen. I think lastly, I will spend a few slides on ablation-related issues. As you know, once you're done the resection, you need to ablate the remaining mucosa. And the standard now is using a Halo RFA, using 360 catheter, and the Halo 90 can be used for islands which are left behind it. And it has got over 90% eradication rate for both for dysplasia and intestinal metaplasia. However, you will see some challenges with where you will not get a good treatment response. So the RFA is refractory in patients who have ongoing reflux esophagitis, large hydrocenia, and quite often you see long segment of Barrett's without any squamous islands, and these are always a bit challenging to eradicate. And sometimes you will see that many of you would have done RFA, you go and you do the 360, come back, following 3 months you come back in, it looks like you never treated them. So these are patients who are not going to be easy to manage. And there is a stepwise way of managing them. This is the data that we looked into in Europe, led by Jacques and quite a few of us who participated in the study. We looked at about 13% of the patients had less than 50% regression at 3 months Halo, and the 4 independent baseline predictors were for poor response. Actively ongoing reflux esophagitis, the EMR scar regenerating with the BE, not with the squamous epithelium, esophageal narrowing with poor contact of RFA, and also how long the patient had a neoplasia prior to the resection. So these were all the predictive factors what led us to think that there should be some alternative techniques that has to be done. Cryoablation is something which can be considered in these sort of patients. I've done a few now in special circumstances, and this is from Rehan's group in London, where they looked at about 18 patients who did not respond very well to RFA and had a cryoablation, and nearly 70 to 80% of the patients responded to it. So there is an alternative now that can be done. So to summarize this nice, good flow chart from Arvind Tinday's group, if you have a Barrett's refractory to RFA, first thing to do is to optimize your reflux treatment with PPI and make sure that the patients do take it. If not, then I send a lot of my patients for fundoplication before I go back and treat them. So if you control the reflux and do an RFA, then patients do respond very well. If they do not, then you need to think about alternate techniques like APC or cryotherapy. And nowadays, with hybrid APC, you can treat a wider area as well. And I'm hoping that the cryoablation will be more universally available. There are a few other things which to take into consideration is the complications about 10% or so with strictures, which usually gets treated with balloon ablation. You can have a narrow esophagus where you can use the channel catheter, which is good as well, or you can use the cryoablation. So in this particular video, I'll just run through a diffuse esophageal stricturing due to graft versus host disease in one of our patients, and typically he developed high-grade dysplasia, and thankfully there was no mucosal abnormalities visualized to do endoscopic resection that have been challenging. In this particular patient, I'm using cryoablation here. There's balloon which will fit into the size, and you can do it with a diagnostic scope, or in this particular case, a 3.8 channel scope. You can see nicely through the balloon, and with the foot pedal, you can see the foot pedal being used here. You can, and this is the aperture where it sprays the cryo spray, and you can ablate it. So this is an alternative approach that can be done if RFA fails, or in patients where there's diffuse narrowing, where you may not be able to get your RF catheter in. Finally, as I showed you, it can be quite challenging, it can be daunting to do all these things, and it's important these sort of things done in a center where there is expertise for an interdisciplinary expertise in managing them as a multidisciplinary team. You need your pathologist, you need your surgeons, you need your radiologist, and a very good interventional endoscopist, all combined together, a dedicated team to do that. Finally, in summary, first thing is you need to get the basics right, high-quality endoscopic examination. I think everyone who's doing diagnostic endoscopy should be able to do that. And once it comes to the stage of managing dysplasia, then it should be in a center where there is expertise to do endoscopic resection, either ESD or EMR. All these expertise should be there to do the check the right choice. Otherwise, you will just choose the one which you are comfortable with. RFA is still the gold standard for ablation. I don't think there's anything still yet which will beat it. APC and cryoablations are alternatives what you can consider, and also don't forget there's surgical management always in all the patients, but that needs to be discussed with the patient and the surgeons and a multidisciplinary team. Thank you, and leave there. And please don't forget about the Perth AGW later on this year. There's going to be a lot of live endoscopy as well. It's going to be 3 days. It'll be exciting. So book your flights now to the West, the Wild West. Thank you.
Thank you, Krish. That's a fantastic talk. Prior to getting questions from the audience, I have one question as a surgeon. Which Barrett's that has no visible lesion should I be referring to Raj or Hamish to have a second look at? Are there any specific pointers in non-visible lesions with Barrett's?
When you would ablate them?
Yeah,
I normally wait. I don't rush in and ablate. I normally wait for 6 months, repeat it, and have a relook. And then if it is still dysplastic coming back, then I would ablate it. So I don't normally rush in and ablate them straight away.
With low-grade dysplasia?
Oh, that's a different situation. So I didn't cover it because I can give a talk on low-grade dysplasia. There are two thoughts across the Atlantic. In Europe, we believe that if it is low-grade dysplasia and on 2 occasions, 6 months apart and multifocal over time, then I would go and ablate. That's what I do in Perth. In US, where the conversion rates have been low, that's based on the pathologist, how they interpret it, then they don't believe in it, they wait and watch. So it depends on your pathologist. If your pathologist diagnosing a lot of low-grade dysplasias, I'll be very skeptical in ablating them. If your pathologist diagnoses low-grade dysplasia occasionally, then I'll take it seriously. So that's what it is.
Yeah, question.
Sorry, thanks, Krish. I've just got a question. So recently some data has come out on long-term follow-up after ablation following resection, and they've shown that there's dysplasia up to 10 years after the resection. So I guess my question is, with the risks, I guess the concerns with buried Barrett's and the difficulty in seeing dysplasia, do you think that maybe we're doing too much RFA?
You mean to say long-term data on recurrence, or?
No, so on recurrence. So people who've had a lesion that's been resected, and this was from the St Vincent's group in Melbourne, I think it was published late last year. They've followed them up for sort of 5 to 10 years post. They've done resection of the high-grade or early cancer and ablation as per guidelines, and they're still finding dysplasia up to 10 years later.
Yeah, that's a good question. You know, most of the recurrences happen in the initial 2 years' time. After that, over time, it comes down. So we looked in the data between Mayo Clinic and Nottingham, and we showed that even at 5 years, it was not going down. So there is a bit of a disparity in the published evidence so far. It again depends on how systematically you're doing the follow-ups and what protocol you're using in biopsy. I think it comes down to the quality of the endoscopy and the original ablation and the immediate follow-up. And when you take it, I call it the exit biopsy. Exit biopsy is when you finish your ablation. I normally use 2 sets of biopsies as the exit biopsy, where you completely eradicated the dysplasia and internal metaplasia. So you may have left some internal metaplasia. If you used only one exit biopsy, then there could have been incomplete ablation and places where you can get it. So I don't think we are over ablating. I think there is a case to ablate once you have resected, and there is maybe some low-grade dysplasia in the remaining Barrett's. So time will say. Thank you.
Very nice. I don't think Raj needs any introduction, so Raj is coming back to talk to us about IM, dysplasia, EGC, and gastric polyps. Thanks, Raj.
Yeah, thanks. Sorry, we're running slightly behind schedule, so I'll crack on. So I'll just try to touch on this, and then we have some time during the MDT where we can also take a question from Slido. So there was one question from Slido as well. So IM, dysplasia, early gastric cancer, and gastric polyps. It's quite a lot to cover. So I'll just try to look at gastric lesions, how we make an endoscopic diagnosis in keeping with the theme which we discussed, and what do we do with them. So these lesions actually are found incidentally. We all do scopes here, and you know that up to about 6% of upper endoscopies would have a gastric lesion. They're usually asymptomatic. They can be divided into this sort of categories, and we'll have more on this later on. The epithelial lesions, though, are quite important. And it has got this cascade called the chorea cascade, where you have atrophy, intestinal metaplasia, dysplasia, and early gastric cancer. It's basic endoscopy. On retroflexion, how do you diagnose atrophy? You look at the body, and you can see that there's loss of gastric folds. It looks a bit pale, and there's increased vessel visibility. So these are all some of the markers to suggest that this is gastric atrophy. We also try to look at the magnification component to it, and I won't bore you with details, just to say that in the body of the stomach, you'll find these roundish type pits like that, and those vessels are what's called as the submucosal vessels. Don't have to worry much about that, but the pits are round if you apply NBI with magnification. And if you go on and look at the antrum, you'll have this slanted or sloping type pattern, and those pits will become elongated, almost like the duodenum. So these are 2 different sort of areas which you can see if you apply the magnification function with some form of electronic chromoendoscopy on your scopes. And when you have intestinal metaplasia, look at white patches or plaques, as you can see here, best seen with NBI on the right-hand side. And when you look at these plaques, you can kind of make out what's called as the light blue crest, which was sort of proposed by Noriya Uedo from Japan. And this has got a sensitivity and specificity of about 90%. So the LBCs, or the light blue crest, can be seen if you look hard enough. So with GIM diagnosis, what do? We risk stratify the patients. Before that, confirm if there's H. pylori and try to eradicate H. pylori. Now, if there's only focal GIM involving the antrum and no other risk factors, if you're convinced you've done a high-quality EGD, these patients do not need any further surveillance, all right, if it's just confined to the antrum. Obviously, if you think that the quality of the gastroscopy is a bit questionable, then you'll have to probably repeat that, okay? Now, if you have a high-risk sort of feature, and this is in keeping with a Western population, right? I'm not talking about Japan or East Asia. So if they've got extensive GIM, they've got first-generation immigrants from high-risk gastric cancer areas, and they're high-risk race, including Asians, blacks, or Hispanics. That's probably, they would score another scope in 3 years' time because of the risk of synchronous or rather metachronous lesions. So this is adapted from 3 continents guidelines, which I looked at a few weeks ago. So early gastric cancer, a demarcation line is important. just like the colon, you'll see that there's irregular microvasculature and irregular microstructure. This is an example of an early gastric cancer looked up close. On the right-hand side here is normal pit pattern and vasculature. I won't go into detail, but just to say that we can sometimes even call the level of differentiation just by looking at the surface pattern, or rather the vascular pattern, if it's a fine network-like pattern or a corkscrew pattern, and I'll show some examples later on. This is a lesion which looks like a gastric ulcer. Obviously, we have to biopsy these areas when we see them. In this instance, there's a clear demarcation line. I find that after you draw a line on endoscopy images, it looks more convincing. But anyway, you have to trust me on that. And there's abnormal pit pattern and vasculature, mostly pit pattern in the center. That was removed using an ESD technique and subsequently closed. This looks like a colonic flat LST adenoma actually. And that was what it was, and we had removed it as well using an ESD technique. This looks like a gastric ulcer, of course. As you go close by and slowly hone in on the area, first with white light, then narrowband imaging, and then magnification, we can actually see the surface of that area. There's a demarcation line around. There's a bit of muck there, but if you can believe me that this looks like a net-like pattern, and this is in keeping with a differentiated cancer. All right, so you can actually see these things if you look close and hard enough. So we removed it using an ESD technique. This is another area here. Looks very subtle. You would think this could be an NSAID-induced or aspirin-induced ulcer. It was not, because of this pattern. So ulcer is there. That pattern there shows a corkscrew type pattern. This was a poorly differentiated adenocarcinoma, which I'm sure Harsh and Sarah would know. We discussed this fellow extensively at our meetings, and we had removed it. If you look at it, that lesion was actually 0.8 centimeters, so 8 millimeter undifferentiated cancer. So the patient's doing well. It's 2.5 years after the procedure. Sometimes it's difficult to see these lesions. This is an area which looks a little bit abnormal. Biopsies were taken, but it's hard to make out what's happening. Maybe, again, as I said, once you draw things, it looks really a bit abnormal, but it was hard to make out. We could only go by gross morphology here, because biopsies previously showed features of an early gastric cancer. I mean, it could very well be other areas, but you need to clean the mucosa well and evaluate carefully. We obviously were a bit biased because we knew previous biopsy showed an early gastric cancer, but after lifting it, you found that that area was slightly puckered, but it lifted really well, so an ESD is not much of a problem. So gastric adenomas, more or less, can occur in about 6 to 10% of gastric polyps. They are solitary, associated with H. pylori. Risk of dysplasia progression is high. They come in all sorts of sizes and shapes, flat, sessile, or pedunculated. And again, be very careful, because 3 in 10 patients, 1 in 3, would have a risk of synchronicity. So there could be other things elsewhere as well. What to do? The present recommended guideline in Australia, outside Europe, America, obviously the Japanese, basically suggest that we need to take this off in an en bloc fashion, so that we've got good, clear lateral and deep margins. Fundy gland polyps, so commonly seen. Just try to remember that fundy gland polyps look like hyperplastic polyps in the colon, and hyperplastic polyps in the stomach look like adenomas in the colon. All right, just try to remember that. That's one key thing. They're usually less than 1 centimeter. They're mostly sporadic, but if you look hard enough, you'll find these roundish type pits. And if you look really hard enough, spend a few additional seconds, you'll find that there's also some capillaries running behind it. Kind of looks like the gastric body, right? Just a little bit more engorged bits. Okay, so this is quite classical. We don't need to do anything unless they're more than 1 centimeter in size. Hyperplastic polyps looks like adenomas. They can develop into dysplasia. They are associated with obviously H. pylori, risk of malignant transformations, about 0.5 to 2%. This is an example of a dysplastic hyperplastic polyp. it's so hard to differentiate, but you can see this area here. And if we go closer, you can actually see that the pit pattern and the vascularity rather is totally distorted. So I'll just stop there, and you can see that totally distorted vascularity amongst many hypoplastic polyps. So we had to remove this in an en bloc fashion. So less than 1 centimeter, eradicate H. pylori, whatever it is, more than a centimeter, resect. But sometimes these fellows recur, and they can come back with a vengeance. You suddenly find a 2 centimeter polyp when it was 1 centimeter a year ago, which you had removed. Neuroendocrine tumors, I won't go into detail, just to say that you would probably know some of these classifications. They kind of have a yellowish type tinge on endoscopy, yellowish type tinge. They can be commonly seen in the rectum as well. They can be divided into 3 types. You can look this up, and you can look this up on certain slides as well. You can see that after biopsying, this was biopsied previously, this nodule, that yellowish discoloration is there. So that's one of the key markers. Once we inject, they actually submerge. So it becomes quite tricky because instead of like an adenoma, which lifts, these fellows submerge because they arise from the submucosa. This was a bit of a complication. You saw that defect over there, which we had to close initially with clips and then later on with something called an overstitch device, which some of you may be familiar with successfully. These lesions are notorious, so obviously when you see that sort of picture with a perforation, this is an imaging workshop, so we need to understand what we look at. If you see something moving in the background, you better sort of be aware, because it's not moving with respiration, it's moving the other way around sometimes. Obviously the yellow color is the other giveaway. So this is a true and through perforation in the stomach, which we close with clips. So these NETs are quite notorious for that. And I'm sure Amol and Honchi will tell you how it's sorted or settled endoscopically. This is a polyp, maybe, but when we look at the surface pattern, remember in the antrum, they're all slanted sort of surface pattern. So it's a subepithelial lesion arising from the 3rd layer. Is this a pancreatic rest? This patient had multiple biopsies, multiple times. He was, I think, about in his 40s and got fed up of seeing us more often than, I guess, his family. So he decided to submit himself to an endoscopic resection, which we did, and closed it up, and it came back as a pancreatic rest, which is quite classical with a central umbilication. We sort of discussed this at length with him, but he wanted this out because we didn't have a tissue diagnosis. There's no directed management or surveillance indicated for these lesions. Lipomas are also seen. So in the stomach, the number of pathological variations are much more compared to the colon. So this is yellowish in discoloration. This patient was referred for resection. We found a pillow sign. We decided to take some samples after opening things up. Took samples, confirmed it was a lipoma. We closed it up, and the patient was on his way. We didn't do anything major for this because the lesion wasn't bleeding, it wasn't obstructing, was detected incidentally. So you can also have metastatic type lesions. This is a malignant melanoma, and sometimes you have to be a bit cautious when you find multiplicity. We always thought multiplicity, many lesions, looking the same, is something which is benign. But in this patient, these lesions were actually in keeping with malignant melanoma. The patient subsequently succumbed to the disease. Inflammatory polyps is something which can be a problem. This is a gastric inflammatory polyp obstructing the duodenum. So we had to do something. And we couldn't quite see the head of the polyp unless we force our scope through. The patient was very symptomatic, so we removed this very cautiously and carefully using different types of knives, and ultimately taking it off in a single piece, and then closing that area up because the risk of bleeding, you can see you can almost drive a bus through that pylorus, but It was about 7 centimeters in size. We closed it up with what's called as an endo loop, which some of you will have experience with tomorrow at the workshop, using it and knowing how to use it, and some clips. So this is in summary some of the lesions in the stomach. So like the esophagus, stomach has got many different lesions. I think you just have to be aware of the subepithelial lesions, but also this sort of adenoma, IM sort of cascade, because you don't want to miss early gastric cancers. So multi-pathologies, multi-shapes in the stomach, sample mucosa if atrophy or IM is suspected, but look before you biopsy. If a lesion is found, try to characterize it. If you're not sure, obviously biopsy it. Most common polyp, as I mentioned, is FGPs. More than 1 centimeter, you're probably inclined to remove it. And with this knowledge, use your best judgment. Know your equipment well as well, and be prepared. If you do embark on some of these resections, there is a possibility of misadventure sometimes. So thank you again, and happy to take some questions. Thank you.
Thanks, Raj. Any questions from the floor?
Raj, there's a Slido question.
Oh, yes. There was a Slido question for Professor Raghunath from the previous session. Can you read that out, Gerald?
Yeah. So if an endoscopist sees a concerning lesion and doesn't intend to do a resection then where should they biopsy so that it doesn't compromise subsequent treatment?
You mean to say finding a lesion in Barrett's and whether to biopsy or not?
Yes.
There's absolutely no problem biopsying the Barrett's. It's in the colon, which we are concerned about. You can biopsy how many times you want.
Thank you.
Thanks, Krish. Just a couple of comments on the previous session's questions as well. With regards to invisible dysplasia, as Krish mentioned, about 90 to 95% of the time we are able to find dysplasia. But if one cannot see dysplasia, just be aware and careful that it's not a nodular lesion we're missing. That's one. Retroflex in the, obviously the stomach, that's two. And the third thing is that sometimes, even if all those modalities fail, acetic acid could be helpful to try to pick up the dysplastic focus. So I tend to use acetic acid, but not all the time.
Absolutely, yeah. That's something I do at the end of it. I finish everything that I can't find.
Yeah.
I finally explain them as we get to it.
Yeah. 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 So that's about 1.5 to 2%. You should have it in all your respective units, including our nursing staff, and you should know how to sort of do that. It's not very difficult. It smells like vinegar, of course, but yeah. Amol.
Yeah, one comment about the hypoplastic gastric polyps.
So we'll use the, yes.
So one comment about the hypoplastic gastric polyps. I fully agree that many of them, when you resect, they come back with a vengeance. A couple of things which we've realized, we should never try and put a clip at the base of these polyps. Because if you put a clip, these come back with a vengeance. The other thing is a lot of these hypoplastic polyps occur in patients with liver disease, chronic liver disease. And in the liver disease patients, they come back even more commonly. Up to 70 to 80% recurrences are very common in patients with liver disease and hypoplastic polyps. So typically the cutoff is about 10 millimeters. So larger polyps we would tend to resect, but in liver disease patients, even up to 25 millimeter lesions, polyps could be left behind if they're not causing bleeding or they're not causing, they're not the cause of anemia. Yeah. Many of them are non-dysplastic actually.
That's a very good point, Amol. Just hold on to the mic for a bit. These lesions bleed though, so how not to put...
no, if they're bleeding, of course, they need to come out. There's no doubt about that. But many of the times, they're not actually bleeding. They have, these patients have varices. They undergo variceal ligation. And see, the other thing is, because of variceal endotherapy, these patients come back for surveillance more frequently. In any case. So you can just have a look at those polyps more often. So it's not really mandatory to resect all of them. At least in the chronic liver disease patients.
Okay. All right. Thank you. Are there any other questions?
Thank you for that. Why don't we move on then? It's a pleasure to introduce Sarah Saxon, Consultant Anatomical Pathologist at SA Pathology's Royal Adelaide Hospital Laboratory, Senior Lecturer at University of Adelaide. And Sarah, of course, has a subspecialty interest in gastrointestinal pathology and is Vice President of the Australian Gastroenterology Pathology Society.
Yeah,
Sarah.
so, yes, thanks, Sarah. So Sarah's quickly taken her seat here. So thank you, Sarah. So we've got some cases, and it's good to have a panel of experts in the audience, as well as the chairs as well. So we'll try to see if we can keep to time and take things from there. So Gerald, just let us know if there's any questions from the Slido. So this case 1, 50-year-old, iron deficiency anemia, had an endoscopy elsewhere. This is an image we got from the referring doctor who took some samples on what appeared to be erythema and antral gastritis, which came back as a moderately differentiated adenocarcinoma. So I just go back. The patient was referred, and we sort of got back to the referring doctor to ask where was the biopsies taken, and it's quite difficult to make out because a lot of times, sometimes these sort of areas which are red in the stomach are just biopsied randomly. The CT scan was clear, the patient was young. We reassessed things later. After a good course of PPIs, perhaps we should have delayed it a little bit. But again, it's difficult. The patient's young and know there's a cancer, but we don't know where the cancer is. We just know that it was from the antrum. So we looked at it with imaging, firstly at the 6 to 9 o'clock position, which was pretty regular. So remember the basic tenet, irregularity of pit pattern and vasculature. And we looked at an area which looked like it had been biopsied, so there are a few biopsies taken. At that area, it looked like the pit pattern was also regular, and so was the vasculature. And then we moved the scope lower down and kind of looked at this area which does look like it's a little bit more redder than before. And we probably found an area which does not quite look right. Although the pits were okay, you can actually see that the vascularity was a bit more prominent, especially when we magnified it even closer. So what you're seeing on the 7 to 10 o'clock position is the pyloric ring. A bit more better views of possibly an area of abnormality very close to the pyloric ring. And as we move the scope down to the 5 o'clock position, that area of abnormality is up there, all right? But this looks pretty regular, all right? So just by carefully assessing that, we kind of worked out where the area of abnormality is or was, and the patient had a laparoscopy prior with actually no sort of macroscopic lesions elsewhere. The patient was discussed at MDT, and we decided to perform an endoscopic resection, actually at the same index second endoscopy, which was hard because we knew that area was abnormal, but we knew this was an area which was biopsied as well. So we kind of took a bigger margin around it, and carefully dissected it using an ESD technique. So we were quite happy with this end result. And then pathology came back. And Sarah, if you can comment on this and let me know if I need to move the slides further down.
Hear me?
Yes.
So this is antral mucosa, and you can see that whilst the muscularis mucosae at the left of the field is preserved, we do have expansion of the lamina propria, so there's a central dropout of glands, and here there is an infiltrative cell population that's poorly cohesive, and some of those cells are of signet ring cell appearance. So if we go to the next slide, I've got a high power view, and you can see that the nuclei are set eccentrically within these cells, and the cytoplasm is vacuolated and finally granular. So this is in keeping with intramucosal adenocarcinoma of poorly cohesive or signet ring cell type. It was a T1A tumour, so confined to the lamina propria. This is a section to the radial margin, and you can see that this would be impossible to appreciate macroscopically, but within the lamina propria there are single cells extending to the horizontal margins, although the deep margin was clear by 0.2 millimetres, and we didn't see any vascular invasion. This is a mucin stain, our PAS-D stain, which highlights nicely those signet ring cells, so that just helps us pick them up more easily. It was also confirmed with cytokeratin stain. Occasionally these cells can look like histiocytes, so cytokeratin helps confirm their epithelial origin. You can see the deep margins nicely clear as well.
So unfortunately, the deep margins were good. Lesion was small, but there were extension to 3 of the lateral resection margins. So this is the problem with this sort of poorly differentiated cancers, and I'm sure Honchi or Nuroshan may also have some experience with this. Perhaps we could have taken some pre-biopsies, even extending the so-called areas here, which we think is abnormal, maybe taking biopsies before we attempt to perform a resection. But the patient was quite anxious, so on the second endoscopy we had to make a call as to where the lesion is and perform the resection. But I think in Japan and perhaps in Hong Kong as well, we could probably, or you would probably do this sort of strategy if you knew the lesion was undifferentiated. What do you think, Honchi?
I think this is tricky because the initial biopsy was moderately differentiated. That means there was actually no histological evidence that this is an undifferentiated cancer. But one hint we might get from here is that the mucosal pattern, although some areas was irregular or the vascular pattern was irregular, there was hardly any well-defined demarcation line. So
Yes.
in some sense, it might give you a hint that this is not a lesion that exposed completely on the surface of the epithelium as evident from the histology. So that's the tricky part. So if you follow strictly the Japanese guideline, whenever biopsy comes back to be an undifferentiated adenocarcinoma, what they do is they do a 4-quadrant biopsy of the visualized endoscopic margin. And when that becomes negative, then the resection would follow the biopsy scars rather than a macroscopic endoscopic appearance, because we knew that the subepithelial spread is well known for undifferentiated type cancers. So that's what we might have done differently.
So how soon do they bring patients back after their biopsy? Like 3-4 days later? Because those
from what
biopsies,
I know, they usually take at least 1 or 2 weeks later, not very, very soon after.
Gregor has a question.
41 years old, this guy?
Sorry?
40 years old?
50, lady.
No family history?
Not that we are aware of, no.
He's going to be gene tested for CDH1?
Sorry?
CDH1, is this not a genetic?
No, it's not
gastric cancer?
CDH1, no.
How do you know?
Because I think she had further workup after she had a subtotal gastrectomy, yeah, I think she had some genetic studies thereafter, if I'm not mistaken. But this was quite some time back. But that's a worthwhile thing to do, to look at that.
Signet cell gastric cancer in young people, it's CDH1 talk and otherwise, yeah?
Negative ones as well. The CDH1 is what we know. But the age is slightly higher. Usually in CDH1, they are dead by 50 if they have mutations. And 50 is slightly on the upper end of the age.
So they're much younger.
Yeah, you will be seeing them in the 20s and 30s. Because, I used to do one hereditary diffuse gastric cancer sessions with Rebecca, which was a centralized service. And almost all of them, and they even have prophylactic gastrectomy. But most of them would, if they have it, they will be dead by 40 years or so, slightly on the higher end age. But the issue here is the signet cells are always difficult to see because it goes underneath. And also, if you see a bit of a corkscrew in your NBI images, which also points towards that this could be more than what we are seeing there.
Yeah. Amal.
Yeah. So I think I fully agree with what Hanchi mentioned. You know, the main disparity and the dispute came in between the first biopsy and the second biopsy, the resection specimen, because moderately differentiated versus undifferentiated, and that's where the difference probably came in, because of, you know, otherwise probably most likely you would have gone much wider.
Yeah. Yep.
So did you have a chance to, you know, review the first biopsy by any chance? Because sometimes it's a pathologist, you know, variation as well, and that could be a, you know, operator.
I can't recall if we reviewed it at a meeting, but I haven't reviewed it for this.
Yeah, so
that's one thing that we usually do. It's probably easier in our system to review outside biopsies before we plan the resection, because that can give us an answer and you can give us this thing. The other point, in this case, probably it would have been a little bit difficult for you to extend your margin on the pyloric side.
Yeah.
That was always going to be challenging.
Yeah.
You know, all the other three sides was going to be easy, but pyloric side is always going to be more challenging, because
so that's why we had to be quite careful and start there first, because as you know, if we start proximally, this will just fall into the duodenum.
The first mucosal incision has to be the pyloric.
Yeah, so we tried our best to sort of follow that margin. And tried to take a bigger sort of margin, but obviously that wasn't enough. Interestingly, she had subtotal gastric. Final histology did not show any residual lesions. I think either Sarah or Harsh would have done the gastrectomy for this patient. So she's done well so far, but CDH1 is worthwhile. Yeah, so and we've got quite a robust upper GI MDT statewide setting here, which they all run, and cases are discussed every year. It's probably 17 or 18 years in the making now. So the only issue is that getting patients back sometimes is a problem in an appropriate time. You know, they may wait on a wait list, and that can be an issue. We'll move on to second case. This patient had a lesion which looked like an erosion. And I won't belabor this detail, but to suggest that if you do have an erosion, sometimes, and if you have the ability to look at it carefully, it can help. So in this instance, it looks like that erosion was obviously biopsied before. So again, we are a little bit biased, but the pit pattern there certainly does look slightly engorged compared to the surroundings. And I'll show a still image there. What do you think, Honchi? Sorry to put you on the spot. But this is an erosion in the stomach. Well, you know, if Sarah's sitting there, probably there's something else happening.
Well, it looks like something, definitely not just an erosion. But if you look carefully, I don't think there's a very clear-cut demarcation line.
Yeah.
But rather, you can see the marginal crypt epithelium are dilated, where the intervening parts now becomes more and more dilated. There are some thinning and prominent irregular vessels beneath. So it looks to me that it's not something on the surface, but something slightly deeper that grows onto the top. So one of the DDX in this case would be a neuroendocrine tumor, I would say. I don't know, but I would just wait for you.
I mean, we had obviously the opportunity to look at this. And Sarah, what are your thoughts?
Sure. So you can see at the left of the field some surface epithelial erosion, and the normal architecture is lost by an infiltrative carcinoma. It's an adenocarcinoma. We called it fundic gland type because it had cells resembling chief and parietal cells within it. And it did efface the muscularis mucosae and extend into the submucosa. So this was a T1B tumour.
Sarah, where's the so muscularis mucosa? Is
sorry,
that?
Next image maybe.
All right.
I think we've only got a couple. So this it's really effaced here. I don't have a pointer.
Yep.
But you really can't make out good bands of pink smooth muscle. It's really, you've got a fibrotic stromal reaction around that deepest gland there. And we measured it, I mean, it's not captured in this field, but we measured the depth of invasion from adjacent intact muscularis mucosa at 100 microns. So it was focal, it was superficial, but however, there was tumour extending to the diaphragm deep margin, really only a single gland, and that green dot is partially covering that, but the deep margin was focally involved. We didn't see any definite lymphovascular invasion, and the radial margins were clear. We did do HER2, that was immunohistochemistry, which was negative, and MMR was intact. So it was a T1B adenocarcinoma, low grade.
So can you tell us, for our benefit, what does HER2 and what does it mean?
Well, it really is to guide treatment, and we didn't know how, at the time of reporting, we didn't know how locally advanced this disease truly was, given the focal involvement of the deep margin, and we didn't know the staging. So we were really trying to get ahead and provide any information that would guide treatment.
I think the patient subsequently had, I think, a close follow-up. You can see here that we tried to get the submucosa, and generally speaking, we try to aim for between the second to third layer as we are getting the submucosa and trying to get underneath it, but occasionally that's not good enough, I suppose, especially if that lesion is sort of pulled, and in this instance we had to use a traction device to pull the lesion in order to cut underneath it. I'll go to the third case, which is quite interesting. So this patient had Barrett's GOJ nodule, which was referred as high-grade dysplasia stroke intramucosal cancer. Somehow the video is not playing. So you can actually see as we are pulling the scope back, the nodule is actually much more extensive. All right, it's much more extensive, and I like what Raghu said earlier, Professor Raghunath, that you have to be cautious about this subsquamous extension. So from almost close to the lower end, this was a lesion which is not 1 centimeter in size. It's actually much larger, and hence you can kind of see that it probably covers about maybe 30 to 40% of the circumference. And in this sort of instance, if there's a suspicion of cancer, there's this debate on ESD versus EMR. I think these lesions definitely should be subjected to an ESD in an en bloc sort of fashion. So these are some images. And in retroflexion, if you're not careful, you'll miss a lot of the extension of the lesion. As you can see there, even with white light, it appeared to be a bit full compared to the surroundings. These are just NBI images, and we went ahead and performed an ESD with a lot of difficulty, given that it was so close to the cardia. So, Sarah, you have the pathology.
Yes, so we had the mucosa was about 55 by 26 millimetres in maximum dimension, and 30 millimetres of it was involved by intramucosal adenocarcinoma. You can see on the right intact squamous mucosa, and then centrally some glandular mucosa with malignant glands infiltrating beneath the intact squamous mucosa. But the deep margin looks clear in this field. If we go to the next image, you could see now well-formed glands of intestinal type or tubular type. So it's a low-grade, moderately differentiated tumour, and these glands are infiltrating the superficial muscularis mucosae only. So that's a T1A tumour, M3 by AJCC staging, and M2 by Stolte. And we didn't see any definite lymphovascular invasion, and the margins were clear. Again, this was a high-power view of some high-grade dysplastic change and then infiltrative glands that are undermining intact squamous mucosa.
So that's the squamous and that's the glands.
And again, another view.
So those are the glands which are...
Yes, infiltrative glands. You can see the parallel bands of superficial muscularis mucosae in which they're
so
between
this
which they lie.
is it like a duplicated MM?
Yeah, so it's hard to appreciate in this picture, but there are certainly muscle bands beneath those glands. So it's only in the superficial muscularis mucosae.
Right, so I think the learning point here is fullness and subsquamous extension. Just be mindful with this sort of lesions. This is just a straightforward lesion. If you miss this, then better think twice about doing endoscopies. Yes. Sorry, but it's quite obvious. You can see the scope is about 1 centimeter, right, in diameter. This fellow is about 5 or 6, but it's sitting in the cardia. And it was very difficult to access. With a lot of difficulties, we accessed this. And I've spoken to Amol about this in the past, Dr. Bapaye. And one way of sometimes doing these resections is to put patients on the either supine or sometimes even right lateral if you want to get better access. I think this was done in the right lateral position, which makes everything kind of upside down when we're doing scopes. We're using something called a dual action clip here because I was worried that the muscularis propria was quite thin. These clips are actually available on the market now. Not trying to promote them, but they can oppose things quite well. So once we oppose the whole lesion centrally, that is, you can then put clips on both sides and close them up like that. So this was the lesion. So it was quite large. Sarah, what do you think?
Yes, so the whole specimen was really carpeted by this lesion, which is an adenoma of gastric type, and it looks pyloric in type. So glands are abnormal from base to surface. If we go to the next slide, here's a close-up. So we've got crypts that are variably tubular and serrated, and sometimes up the top there's even early sort of cribriform type architecture, so quite complex architecture, and a variable atypia which is high grade. So it was called a pyloric gland adenoma with high grade dysplasia. There was very little normal mucosa, if any, in the specimen to assess for atrophic gastritis or Helicobacter gastritis, but there were foci of intestinal metaplasia, which would be in keeping with a chronic inflammatory process. If we go again to the next. Now, there was involvement of deep and radial margins. Whilst we've lost a little bit of ink there, you can see there's diathermy change extending up into those neoplastic glands. That's a high power view. And then this is a horizontal and radial margin with those budding glands at the radial edge. We do mucin stains in attempt to subtype these tumours further. This was a MUC6 mucin stain, which highlights mucin of pyloric type. So that was positive and quite extensive throughout the lesion. And the following slide is the MUC2 immunostain for intestinal type mucin, which was negative.
Right, so I guess the learning points are that, the access is difficult. And perhaps Amol or Honchi will discuss a little bit later on how do you ensure that the muscle is intact while you're doing this in a very difficult sort of location. It's tricky sometimes, and I'm sure if you have a perforation, you would try to close that and continue.
Yeah, I think so. So I think the right lateral, I don't want to take any credit for it because this was something which, the Japanese, particularly Dr. Saichiro Abe, he recommended this position, the right lateral position, when I was stuck in this kind of a case a few weeks ago.
Yeah.
And then we discussed because, so I think the right lateral position is particularly useful for a lesion which is dead in the fundus, right in the middle of the fundus, not near the G junction. So that's very important. And there, your scope actually, you do it in a little bit of a long loop position rather than, because that's how you get a more tangential direction towards the, in the submucosa. Otherwise, it's more end on, and then we end up damaging the muscle more often. I agree that, the muscle in this area is very thin as compared to most of the rest of the stomach, particularly the antrum. And therefore, I think, and plus added to that is the difficult position. there's more chance that probably, we are going to end up in some muscle injury, little bit of these things. I think, of course, we have to complete the procedure and use clips judiciously to close the muscle defects. And of course, now with the wider clips and the DAT clips that you demonstrated, I think we can even have a wide field closure as we can have that. Whether a complete wide field closure is required or whether muscle to muscle, that's, I think, depends on case-to-case basis.
All right.
I definitely agree with Amol that this might not be the exact case that you do it in the right lateral, because it's actually somewhere slightly on the lesser curvature side, not exactly on the dependent area. The benefit of doing it in the right lateral is that you now do not have the fluid being submerged into the lesion, and you have some gravity to help you to lift up the lesion. But this is not exactly where. But somewhere along the line when you're doing the procedure, you might need to change position.
Yeah.
The other thing is the access. So that means the most difficult part would be the top part near the fundus area. Then for that part, if you have the availability of a multi-band endoscope, that probably is the most helpful thing.
Yeah. So we don't have the multi-band in
some
Australia.
form of traction device probably will need to be done.
So we did change the patient's position midway through, as far as I recall. But we don't have the multi-band here yet. Maybe Niroshan may get it soon. I don't know. So last case, this is hot off the sort of thing, and won't be long here. I know we've got tea. This lesion was referred as a 1 centimeter nodule, and we did this procedure on Wednesday, 2 days ago. So as we are looking, and we realized that we only had 30 minutes left on our scope list before lunch break. We had to make a call as to how to take this off. But what's interesting is, despite biopsy showing high grade, as we are looking very carefully, you can actually see that there's a cancer within that high grade dysplastic lesion. So there was no choice. We couldn't cut this into multiple pieces because of the suspicion, and hence proceeded on with an ESD, which was not very prolonged. It took us about an hour, and it was done. Patients still here, but staying somewhere close, and will fly back to Alice Springs on Saturday, I think. What's the pathology, Sarah?
Yes, so there was about 25 millimetres of high-grade dysplasia arising within intestinal metaplasia, and the dysplasia is clear of the radial margins. And then within that focus, there was 20 millimetres of intramucosal adenocarcinoma of moderately differentiated or low-grade appearance, and it does extend into the space between the duplicated muscularis mucosae in this case. So yes, I think slightly to the left there, and then you've got some larger submucosal vessels to the left of the field. So you can see that it's going in between the reduplicated muscle bundles. So it's a T1A M3 by AJCC staging and by Stolte systems. So we've got some infiltrative glands there. We couldn't see any definite lymphovascular invasion. The deep margin was 0.4 millimetres clear, the radial margin 0.9 millimetres clear, and just a little bit of non-dysplastic IM at the radial margins. That's just a high-power view of the malignancy there. That was just a photo of the surface papillary component. And then this was the non-dysplastic intestinal metaplasia at the horizontal margin.
There was a mention of possible vascular invasion.
Yeah, I said suspicious but not definitive.
Okay.
I don't think that helps you, does it?
No. We've got two very experienced surgeons on the as chairs. So what would you recommend, Harsh, if there's vascular invasion?
I'd still do close endoscopic monitoring. You've got positive margins, you've got T1A.
Margins were clear.
Negative margins, sorry. All
but there's vascular, possible
suspicion, but not definite.
Yeah. So
I'd probably do close endoscopic surveillance.
And how often is that?
That's a good question. I don't have an answer to that.
Like
3 months?
3 to 6 monthly. And would you do CTs every year for 5 years, perhaps? Or not really?
I'd do a baseline CT.
Yeah.
that's all clear. I wouldn't think there was any.
Okay. All right. Sarah, anything different? We
No,
haven't put
I
this
agree
up
with
for
that.
MDT.
I think it's hard for you to do more frequent endoscopies in the current system, isn't it? I
Yeah.
mean, to do more than 3 monthly. And it's stressful for the patient as well.
Yeah, it is. The patient still got the rest of the Barrett's, which we need to sort out. So that's the other thing. I don't think there'll be any sort of cancer left behind in the scar per se, but obviously the other segments of the Barrett's need to be looked carefully for synchronous lesions and then RFA'd, if we may. PET scan. Yeah. How often after an ESD? How long after an ESD? 4 weeks? 8 weeks? 8 weeks, okay. I think that's about it. Yeah, so careful assessment of the lesion, I think, is important. And if there's any chance that you find this on an index endoscopy, I think targeting the appropriate area is important. So we'll break for tea and then come back sharp at 3:50. Sorry, it's quite a quick turnaround. Thank you. Sorry to put you through all of that, but
I have to excuse myself for today. The
Thank
rest
you.
I'm
Yeah.
going to go and
Sorry.
grab
Yeah.
Sophie.
Okay.
Gabrielle's got one more week left in Perth,
Okay.
and then we're all
Is she all right?
totally back.
Not really.
Thank you.
I could have uploaded because the speed is pretty low, but I have an HDMI. So is it okay if I can present my? I promise I'll share those slides with Raj. In any case, that doesn't matter.
I think it should be this.
Yeah, but maybe just. Yeah.
Okay, this.
Okay, I think we're running a little bit behind schedule, but just to let everyone know, we've updated the slide there, and you can see the QR code there. So if you want to just scan the QR code, it's also available on the other end of your booklet. You can then post questions. We won't know who you are. So, if you have questions about any of the talks or the preceding talk, just put your questions there. And Gerald will pick those questions up and put it forth to the chairs and the speaker. So I think we better get started because we're about 8 minutes late. So just before that, I'd like to introduce you to all of the chairs. So we've got Biju George, who all of you may know, is a senior consultant gastroenterologist and interventional endoscopist, and comes with a lot of experience. So he'll chair this session together with Dr. Derek T., who also works at the Lal McEwen and is the head of IBD and does a lot of EUS as well. And on Derek's right is Dr. Anthony Farfus, who's our savior with regards to hepatobiliary surgery. And any of the problems we face with ER, CPs or whatnot, we'll call Tony. So the three of them will chair the next session. Thank you, guys.
So welcome to the second session. We have an exciting talk by Dr. Amol Bapai. Most of the people here know Dr. Bapai. He has been around all over the world speaking about various endoscopic techniques. And he has published extensively, and he comes with his vast experience. He is going to educate us on submucosal lesions in the esophagus, how to diagnose and what to do. Amol.
Good afternoon, and thanks Raj and the entire team for having me over. It's my second time in Adelaide in the last so many years. I was here before COVID, and always a pleasure to come back over here and have, see all the familiar faces, and thank you so much. So subepithelial lesions in the esophagus, how to diagnose and what to do. No disclosures as such, but let me disclose one thing, that when we are going to talk about these two questions, how to diagnose and what to do, I think there's going to be a lot of overlap between my talk and Hanchi, with your apologies. I may be, there may be some overlap. I'll try and minimize it as much as possible, but some of it is just unavoidable. So let's start with the terminologies. What do we, SMT, SML, or subepithelial lesions? So now I think for a uniform need for terminology, subepithelial lesions is the way to go. So we call it all subepithelial lesions. Usually these are all going to be asymptomatic, incidentally detected. And the typical incidence for gastric lesions is 0.4. And some common SELs, esophagus, we're going to focus on the esophagus. So leiomyomas, varices, granular cell tumors are the duplication cysts. And some uncommon ones in the esophagus again, GIST, squamous epithelial papillomas, fibrovascular polyps, and so on and so forth. I'm not going to read through all that list. Basically because the incidence of esophageal subepithelial lesions is about 1 in 300 endoscopies, and overall about 0.5 to 1%, that's what some review articles say. So when do we do something for these lesions, and how do we do whatever we do? So whenever we are evaluating these subepithelial lesions, these are some of the parameters that we consider when we are looking at these lesions. So we look at the size, we look at whether it's extraluminal or subepithelial, that is whether it's just a compression from outside. Then the location, again in the esophagus itself, it may be upper, mid, or lower at the G junction. Cystic or solid is an important differentiating factor. Diagnostic differentiation could be on gross after resection or could be on biopsies, histology. And we need to, based on all these parameters above, we need to predict kind of its benign or malignant potential. And based on that, make a decision whether we observe or follow up or resect. And that's how it is. So this is an algorithm that many of us may have seen in review articles, but let's just focus on the first row of this, that lesions under 1 centimeter can just be observed, and they probably need an endoscopy after about a year or so, just to make sure that the lesion is not growing in size. And there's nothing more that we need to do at that point in time, and surveillance just is enough. However, for the larger lesions and the more important ones, the evaluation is using endoscopy, EUS, endoscopic ultrasound, with or without biopsies, and then imaging. And ultrasound obviously is not important for the esophageal ones, but the CT scans. And then there may be some additional specific tests. So these are particularly some lesions in the esophagus, typically a leiomyoma in the esophagus, or this is a typical molar tooth kind of an appearance, a whitish structure, which is a granulosa cell tumor. This is how a duplication cyst would look. Again, differentiating between a leiomyoma and a duplication cyst sometimes can be a little bit tricky on endoscopy alone, because both of them have a very similar appearance. And of course, varices. So this is an image which I borrowed from my presentation on gastric and upper GI SELs, but I want you to focus on the esophagus and the G junction now. And as we can see, the commonest lesions are the leiomyomas or granular cell tumors. Occasionally there may be a gist, or there may be some duplication cysts. Otherwise, mostly others are quite rare. By appearance, we all follow the Yamada classification, wherein we have a type 1 to type 4 based on whether they are endophytic or exophytic. And this becomes more handy when we are planning a resection, particularly in the esophagus, because that is how we're going to be deciding whether a tunneling resection can be performed or not, and that is how it's going to be deciding. Some classical signs, and some of these pictures are from the gastric side again, to demonstrate the rolling sign or the pillow sign or the tenting signs. So the pillow sign is typically for a lipoma, which is more commonly seen in the stomach, and a rolling lesion, rolling sign denotes that the lesion is in the mucosa muscularis mucosae or the submucosa, but it is free from the muscularis propria. And then a tenting sign actually indicates that it's probably from a deeper layers. And how do we size these lesions? We can use a guide wire with your markers, or we can use an open biopsy forceps, or we can just use the scope as this thing. That's again in the fundus. So I've again tried to narrow down onto the esophageal side. The leiomyomas, varices, granular cell tumors, duplication cysts, or occasional schwannomas. So they're location-wise, they are in the esophagus, cardia, or the upper body. These are the Yamada types. And the color, surface, and then whether they are movable or not. This is mainly based on the endoscopy appearance. And therefore, this is an algorithm that one can follow. If we see an subepithelial lesion, find the, based on the location and the color, we can differentiate and rule out cyst or lipoma or vascular lesion, and then based on the cushion sign, and then we can perform subsequent these things. So sizes more than 1 centimeter should be subjected to an endoscopic ultrasound. That's where EUS comes in. And what is the role of EUS for subepithelial lesions? So this is one of the most important tools for identification and differential diagnosis. It gives us information regarding the fact whether the lesion is intramural or extramural, the layer of origin, its appearance and the ecotexture, vascularity, and the probability that whether the lesion may be harboring malignancy or not, and also some points about perilesional lymphadenopathy if there is anything. It can further give us an ability to perform an EUS-guided fine needle cytology, or more often biopsies nowadays, because cytology is rather rarely performed for subepithelial lesions. And these have been, FNBs have been shown to be superior to surface biopsies in many situations. And also, it is safe and effective for follow-up of these patients. And what is the aim of performing EUS for these? We aim to get a morphological diagnosis, and we get a tissue diagnosis if it is required. And this is where there is a cardinal difference between subepithelial lesions in the stomach versus the esophagus. In the stomach, invariably we will try and get a preoperative tissue diagnosis, and we will use EUS more often for that. But in the esophagus, since we've seen that most of these lesions are benign lesions, they are leiomyomas or granular cell tumors, and GISTs are very rare in the esophagus, very often the need for an FNB, preoperative FNB, is not required. I will come to the indications where it is required in a few times. But what we need to do is, based on the EUS, we need to define the need for resection and also assess for suitability for endoscopic resection. And what scope do we use? Do we use the mini probe? So smaller lesions, less than 10 millimeters, better scanned using a mini probe. Larger scope, larger lesions can be targeted with the radial or the linear scope. But the radial is superior to linear for layer demarcation and visualization, whereas linear is obviously mandatory for if you want to do an FNB. For esophageal lesions, typically a balloon inflation technique works superior, whereas in the stomach we have to use a water immersion technique. And whenever we are dealing with small lesions, where again, it's questionable whether the lesions really need an EUS evaluation at that time, but if we really want to do it, then try and localize them endoscopically and then switch to an EUS view. That's how you will probably minimize your time, the time that you will waste. Otherwise, it's really difficult to identify. So what do we see? We try and look for the transition zone. We try and look for the size and echopattern pattern of the tumor, relationship to our adjacent organs and lymphadenopathy. And this is again, so just to look for the sensitivity and accuracy of submucosal versus extraluminal. And EUS is far superior to all other modalities in this aspect with a sensitivity and specificity of around 87%. So layer of origin, we have to locate and we have to scan in 3 locations, at the center and at the right and left borders. And particularly for larger lesions, look at the transition zone, because this is where you will be able to identify the layer of origin. So 2 videos again. So this is a granular cell tumor in the esophagus. Here you can see it is arising from the second submucosal layer, 3rd layer, whereas here we can see that it is arising from the deep muscle layer. And it's completely different, we can see that. And that is what is most important. We can see it is coming out from the deep muscle layer, from the 4th layer. And that determines how we are going to resect it, because lesions up to the submucosa can be resected using an ESD technique or an EMR technique. But lesions deeper than that require other techniques, which we'll come to. Cystic lesions, again, they're often in the submucosal layer, but sometimes can be in the muscularis propria layer. What is important to remember that although they are mostly anechoic, sometimes they will contain layered contents, and therefore they can masquerade solid lesions. And therefore, some of us may want to stick a needle inside, but that can lead to a high risk of infection. So that is where we have to try and, so one thing that we can do is sometimes just poke the needle sheath onto the lesions if they are submucosal, and see whether there is any movement within the lesion. And if you can see movement within the lesion, you can probably demonstrate that it's probably layered contents rather than a true solid lesion. And of course, how do we differentiate between a bronchogenic cyst and a duplication cyst? So the bronchogenic cyst typically would be slightly farther away and probably would be outside or in the deep muscle layer, whereas a duplication cyst, you typically be within the submucosa or in the superficial muscularis layer. A word about GIST, and of course, Hanchi will cover this in detail, but I just want you to focus on this point, these 3 words. It's rare in the esophagus. So most GISTs are going to be in the stomach, but when I say the esophagus, it is quite common at the G junction. So we have to be careful about subepithelial lesions at the G junction. These are the lesions which will probably require a prior biopsy. So how do we perform tissue diagnosis techniques? For the esophagus, again, amongst all these techniques, EUS FNB or an endoscopic resection directly are the ways to do that. and FNB is superior, and overall diagnostic rate, rate is around 80 to 90% for lesions more than 20 millimeters. But smaller lesions, the yield is extremely poor. So be very about, wasting your time and the patient's time on that. So US and endoscopy put together, these are some of the comparators, and based on the AGA clinical practice update, GIST, leiomyomas, then we have varices, granular cell tumors, and inflammatory fibroid polyps. And this is how the duplication cyst looks. Coming to the last part of the talk, which is about endoscopic resection for esophageal lesions. So which lesions do we resect? We've done all the evaluation, we've done all the workup, and so we have to now decide which are these patients which we should resect and which we should not. So any lesions which are symptomatic, and in the esophagus the commonest symptom would be dysphagia, although we must rule out other potential causes for dysphagia before labeling the dysphagia to be related to this subepithelial tumor. Because most of these leiomyomas, even though they are 3 or 4 centimeters in size, they're not this thing. Lesions without clear characterization despite attempts at tissue diagnosis, lesions with an obvious malignant potential, lesions demonstrating an increase in size and follow-up, and for an endoscopic resection, up to 3.5 centimeters is usually considered as the limit, but extended indications can allow up to 5 centimeters. And patient preference and apprehension is an important aspect. Most esophageal subepithelial lesions, again, let me remind you, are benign, and they may not require resection. Surveillance can be an equally good option. So, tissue diagnosis, or do we do it always or selective? We don't do it for all because most of them are benign. Most of the smaller ones can be offered surveillance. And smaller lesions, the yield is very low. And a size increase demands resection in any case. So which are the lesions that we would resect? When the diagnosis is in doubt, if we are going to perform a piecemeal resection, and if there is a patient preference. So what are the resection modalities? Mucosal or submucosal lesions, we perform an EMR or an ESD, whereas muscularis propria lesions, in the esophagus, we will typically perform a tunneling procedure, a stir procedure, submucosal tunneling, and EFTR or a full thickness resection is not for the esophagus. It can be performed in the G junction itself. So this is a typically, muscularis mucosae lesion, not very common, leiomyoma, but patient wanted it out, and so we performed an ESD. But this is, the reason why I kept this is because some of these lesions, which are endophytic, it is difficult to differentiate whether they're arising from the MP or the MM layer. And we may sometimes land up trying to attempt an ESD, and then you have a central attachment which is arising from the muscle. And that can be really tricky because you've opened up the esophagus and the mucosa, and now you're stuck with a big gaping hole out there. So that differentiation is very important. Which are the areas we perform stir on? So all the green areas we can perform the stir on. So for the esophagus, again, this area. And what stir does is actually it prevents and it kind of protects from a full thickness perforation because we are using the tunneling technique. So we are dividing, separating the mucosal incision from the muscle area. And this is how we're performing the dissection. And then we just perform a mucosal incision to close, clips to close the defect. G-junction lesions can again be performed by, treated by a stir, but locating the lesion within the tunnel can be challenging. Very often we would inject beforehand and then try and orient our tunnel in the same direction because otherwise we can miss the lesion. And that can be very tricky. So this is a lesion at the G-junction, and mind you, I don't have the histology picture over here, but this lesion turned out to be a leiomyoma. Large lesions, we may need to perform an intracorporeal morcellation. So this was a very large lesion, and this is something that we've described now. And we can actually resect and cut it into pieces using a snare. One has to be mindful that we need a prior tissue diagnosis of it being a leiomyoma beforehand. And morcellation should be performed before disconnecting the tumor from the attachments, otherwise it's not going to work. Therefore, to summarize, upper GI endoscopy and EUS are the primary modalities to evaluate esophageal lesions. And characterization using size, location, endoscopy, and EUS can be done. Lesions under 1 centimeter, they do not require any evaluation, only surveillance. Larger lesions will require probably a movement towards evaluation, tissue diagnosis, possibly, or endoscopic resection. Tissue diagnosis can be performed using a selective approach towards EUS FNB, and EMR, ESD for mucosal or submucosal lesions, and STIR for the MP layer lesions. Surgery for larger lesions or those which are not suitable for endoscopic resection, and we have to remember that surveillance remains a valid option, but patient preference should be given an important consideration. For those of you who may be more interested, feel free to join us in Pune, in India, in July, and we'll have a good time over here. You'll learn a lot more about this. Happy to take any questions. Thank you.
Thank you, Amal. Any questions?
I do have a question. Dr. Amal, thank you for the excellent talk. I would like to ask our patients who are not keen for repeated endoscopic procedures, are there any roles for radiological imaging, especially MR, for surveillance of the cystic lesions rather than EUS, especially for like duplication cysts?
Okay, so they at least need one index endoscopy and EUS for characterization. And subsequently, if it's a low-risk lesion, and if it's kind of a benign, the lesion is expected to be benign on EUS appearance morphology as well, then if you're doing the imaging only for size, then I think an MR is a fair judgment call. That's not a problem.
Okay, thank you.
Amal, I've got a question.
Yeah.
Very clear talk. We always find it difficult deciding what to do when they're between 10 and 20 millimeters.
Right.
Especially with EUS and FNB not yielding the diagnosis. When you're talking to a patient, is in your mind, are you thinking surveillance and what interval? Talking to a patient about endoscopy surveillance or always with EUS? And would there be benefit in removing those lesions, especially in a young patient that might want surveillance if it stays?
Right. So, see, the guidelines are not very clear yet when it comes to only esophagus, but some of the practical points that we use is, the first thing is we tell the patients that esophagus, and particularly in the upper and mid esophagus, cysts are practically unheard of. So they need not worry about a malignancy, a cancer out there. And so they can definitely follow up with surveillance and things like that. G-junction lesions, we have to be more mindful because you can get that occasional cyst out there. And then you would need a tissue diagnosis before labeling that as a leiomyoma. And that's going to be difficult for that 10 to 20 millimeter lesions, and wherein probably a patient preference of getting it out, particularly for the younger patients, well, it's a fair thought. And probably that's one of the major indications for a resection. For many of the esophageal subepithelial lesions, I think even Honchi will agree to that. Most of the Chinese centers also report the same. Because, see, we have to be pragmatic about this, that young patients, many of these lesions, we find them in their, these patients are in their 20s or 30s. And when you tell them about surveillance, annual, or even once in 3 years, you're looking at 40 or 50 years of surveillance. Is it practical? And these lesions are about 15, 20 millimeters. You can get them out. And, if it's a leiomyoma, forget about it. I mean, that's how it is. So it's a fair thought. And it needs to be a conversation with the patient, and you have to make the patient aware. And that's the reason in the last slide is also I've mentioned that patient preference remains a very important factor when we take a decision about how we proceed with these treatments. Of course, we have to reassure them that many of these lesions are not cancerous.
And what's your surveillance practice if the patient decides to go for surveillance?
I'll call them once after a year, and if there's no change, probably call them after, in 3 years' time, I think. And probably, keep doing that. Because most of our patients, they'll in 3 or 4 years, they'll say, doc, get it out. That's what is going to happen. Yeah, because who's going to come every 3 years? And otherwise, they'll just forget about it. They won't come at all. And it's fair. I mean, I would probably do the same thing, if I were in their place.
Thanks, Amol. Thank you very much.
Thank you.
Okay. Moving on from the esophagus to the stomach, we have another one of our international faculty, Associate Professor Ong Chi Yip. Associate Professor is currently the Clinical Assistant Professor at the Department of Surgery Surgery and Faculty of Medicine at the Chinese University of Hong Kong. He is a global leader in upper GI cancer management with a specific focus on minimally invasive and robotic techniques for early GI cancer. He will be guiding us through the diagnosis and therapeutic dilemmas of gastric submucosal lesion today. Thank you.
Thank you, Dr. T, for the kind introduction. And I would like to thank Raj once again for inviting me to this beautiful city of Adelaide. This is my first time in Adelaide, so I'm really amazed by the nice weather and the nice city. So I'm going forward from Amol's talk. So fortunately, he made a lot of introductions, so probably I can skip most of my slides. And I will focus maybe this time a little bit more on intervention, because that's what maybe Amol didn't touch on too much. But anyway, I think we all know about this. So the definition of so-called SEL, or subepithelial lesions, are those that actually looks like harboring something beneath with the normal overlying mucosa. In fact, it's being increasingly detected, maybe because we are now having much more high-definition endoscopy and widespread availability of endoscopy. So almost all patients would have undergone some form of endoscopy in their lifetime. And one point to note is that as opposed to esophagus, where majority of these lesions are probably leiomyomas or non-neoplastic or non-malignant lesions, more than half of our lesions in the stomach would be just where they do have malignant potential and would may have eventually risk of metastases. But one point to note, I think echo what Amol mentioned is, well, delineating the exact diagnosis, it's not that easy, and the list of differentials are pretty long. And if you really see a smooth mucosa, getting the mucosal biopsy, in fact makes no sense, because all you would get from our pathologist is, oh, there's normal gastric mucosa. But yet, there are so many different differentials out there which could mimic the same thing or look similar things. So in fact, I look at this interesting paper published from the Korean group where they look at some natural progression and incidence. And you'll notice that the range of incidence of these incidental subepithelial lesions from the whole upper GI tract ranges from about 0.7 to up to 2-something%. And if you look into the histology, in fact, in the stomach, now you will notice that majority of them are GIST, followed by ectopic pancreas, leiomyoma, lipomas, and other malignancy or even neuroendocrine tumors. And one point that is quite important is the larger the size of these lesions, the higher the chance of these are being malignant or pre-malignant lesions. So size matters a lot. So when we are managing these, or we're thinking of what to do, I think we should think about a few things. So is there really true pathologies? Sometimes it's just a compression from surrounding organs. What is the likely origin or the pathological diagnosis if this is a true pathology? And should we be resecting them, or should we just be surveilling them? This is mentioned just now by Amol, actually. And if we are to resect them, whether we are doing an endoscopic resection or whether we have to go for a surgical resection. One thing is, even though it looks like a so-called submucosal lesion, but still keep in mind that these lesions sometimes do have changes on the mucosa, especially for neuroendocrine tumors. So a lot of them, in fact, would have mucosal changes. For example, some dilated vessels, sometimes congested mucosas, and on neuroband imaging, you may even see some suspicious changes. And these should be taken biopsies, and you might even have the answer without the need for an EUS. Of course, EUS is important. I would not elaborate too much because Amol has already mentioned all the important things and all the essential stuff about EUS. And all that you can see is what is it beneath, and the layer, that origin of the particular lesion would give you a pretty good answer of what the lesion could be. And of course, there are signs that suggest this could be a malignant lesions when presence of irregular surface or growth on endoscopy or on EOS, where you can see some echogenic foci, cystic spaces, irregular borders, high vascularities, etc. And these were indication that you might be considering FNA. So unfortunately for small lesions, I think we all agree that these lesions would have pretty low diagnostic yield on EOS, even with the latest FNB needles. So these are the areas where controversies exist, whether or not you should do an attempt at biopsy or not. So going back to GIST, probably the most important pathologies that we'll be talking about regarding the gastric subepithelial lesions. So I think you're all familiar that these are lesions with immunochemistry positive for the c-KIT, could be associated with familial syndromes, and they do have potential for malignant changes or even metastatic presentation. So for many years, we've been following this meatinine criteria to determine the malignancy risk based on different sizes. And in particular, for those lesions that are less than 2 centimeters, in fact, we do know that the risk is low, but it's difficult to ascertain how low is low or whether we can safely disregard them or anything. Especially if you do not have a histology to prove the mitotic figure. So for this particular scenario, so for less than 2 centimeters in size, the behavior is uncertain. And from literature, we know that around 10% of these would increase with time, in terms of size. So that comes to the controversy in terms of resection or not for GIST, especially for smaller ones. So if you look into guidelines, in fact, there are contradictory in the different guidelines. For ESMO, the ESGE or Japanese guidelines, they actually suggest resection of all histologically confirmed GIST. But when to do histological confirmation is a subject to discussion. And for those Asian consensus and NCCN, they do actually recommend that for those GIST that are less than 2 centimeters, you only need to resect those that have high-risk features. Meaning on EOS or on histology, you do harbor some high-risk changes. And in the ACG guidelines, they did not mention any recommendation because of the insufficient evidence. So ultimately, for small GIST less than 2 centimeters, the progression risk is low, but you cannot neglect them. But if you subject them for surgical resection, then you might be over-treating them because the morbidity of surgery was still considerable if you have to resect something in the cardia, for example, and you might end up with a gastric deformity where patients' quality of life could be affected. So this comes to the core about whether or not we can do endoscopic resection for such small GISTs or even larger GISTs with low-risk features. So these are some of the information or guidelines that have been trying to structure all the different types of endoscopic resection or full-thickness resection. So we have been discussing EMR, ESDs. Those are targeted towards lesions arising from the mucosa. But when lesions arise from the muscle layer, that means you are likely requiring resection of partially or at least partially the muscle. And in that case, the two main options would be either doing a full-thickness resection or a tunneling resection, which would have been coined as exposed DFTR by the ASG group, subdivided into tunneling or non-tunnel technique. There's another subgroup where there's non-exposed, and these are device-related full-thickness resection, such as the FTRD resection device. So we do have to think about our workup. So as mentioned by Amol, a combination of OGDs, EOS, and also CT scan would tell you a lot about the morphology of the lesion in terms of the access by endoscopy, difficult location by surgery on the other hand, because well, I'm a surgeon, I know which location would be particularly difficult, like in the cardia, in the antrum, or even some areas where there are a lot of mesentery attached to the stomach. And the size, of course, the larger the size, the more difficult it is to retrieve through the mouth. And it depends also on the shape, because an elongated lesion might be easier to retrieve than a really round lesion. And of course, the morphology, being endophytic or exophytic, and whether or not there's any high-risk features such as ulcerations or high vascularities on the preoperative assessment. There is advantage of endoscopic resection over surgery. We're not requiring any abdominal incisions. There is less wound pain. You're actually resecting much less normal gastric mucosa or less gastric tissue. So as a result, you have less gastric deformity, and you are able to resect lesions even at the extreme of the stomach, like in the cardia or even right next to the pylorus. And because of we don't really need to dissect any arcades, the neurovascular bundles to the stomach, there is a potential reduction in gastric functional outcome loss. So the two techniques commonly used for these lesions, EFTR or STIR. So there are pros and cons to both. The EFTR definitely has a high complete resection rate and suitable in almost all locations in the stomach. But that comes to the drawback of risk of full thickness defect and the difficulty in closure and also potential of spillage and contamination. While on the other hand, a STIR procedure would be much easier to close the incision because it's just a linear mucosal entry. But as mentioned by Amol, it's not available or it's not suitable in certain locations, like in the like where in the fundus or in the greater curvature, where tunneling is almost impossible, and it's quite difficult to retrieve a lesion en bloc if you're considering a GIST, if it's a large size, through the tunnel opening. And of course, within the tunnel, because the space is quite limited, then you have very close resection margins. So what we do mostly is endoscopic full thickness resection, especially when GIST is being considered as the potential highest risk. So you can see, for example, so most of these lesions arise from the muscle layer, and you invariably you would be resecting part of the muscle, and you'll be seeing extra serosal fat or even a full thickness free peritoneal perforation. Well, this is probably a bit scary for gastroenterologists, but with time you get used to it if you've done enough. And fortunately, I'm a surgeon, so I've seen enough before, even before starting these. But in fact, we do now have quite good methods of closing defects. So Raj mentioned the use of the dual action clip device. So this is one of the application which you can actually close it quite nicely. So taking this as an example, you're actually opening the two prongs of the dual action clip, and then you can approximate the mucosa quite nicely and achieve a secure closure like this. So usually for a defect of such size, 2 or 3 dual action clips would help to linearize the entire defect, and then you can close it subsequently just with a normal large size clip. So this is one of the example. You're opening one side, grasping it to the other side, and then grasping the opposite mucosa and achieving a secure closure like this. Okay, so because of time, I would just show. So at the end, this is what you will see with a complete closure like this. Of course, we have other methods like the overstitch. This is another video showing how overstitch can be done. Another large, this was about 3.5 centimeters, so and ending up with a large full thickness defect. With the overstitch, again, you are able to close these defects quite securely. Then, okay, I will not show the entire video. So basically, with a running suture, with the overstitch, you will be able to close it, even such a large defect, very nicely. So we actually did a comparison between EFTR and STIR and found that with en-bloc resection rate is much higher with EFTR, especially for GIST. So that actually has a main bearing because in that case, you will have much higher curative resection rate. So, of course, there are certain concerns with upper GI just pure endoscopic resection, whether or not you can achieve artery resection or whether you can close a full thickness defect. I think for these two, we're having more and more confidence. But the main problem is for lesions that are larger, is it good to attempt endoscopic resection? Maybe more than 3 or 4 centimeters, these will be pretty difficult to retrieve by the mouth. And so that comes with the other option is you can actually do something working with a surgeon. So this is called a LEX procedure, where you can actually combine endoscopic and laparoscopic resection in retrieving large GIST. So this is the endoscopic part. So endoscopy, you resect the mucosa up to the lesion and expose the entire muscle layer. And then, in fact, you can then, so you can see the tumor here, and you're actually staying outside of the tumor until the point where you can actually puncture the muscle and enters from the inside to outside. And now you can actually in real time see it on the laparoscope where the scope comes out, and then you can actually core out the entire lesion. So this is called a LEX procedure, and it's actually one of the good options for larger GIST, but you don't want to do a major gastrectomy procedure. And then you can just use the energy device to completely resect the entire lesion and followed by suturing of the defect. So the drawback of this is that you have potential contamination. And so the alternative option is to do a non-exposed procedure. This is called a cleanet. This is something different because this time round you inject the lesion around with a solution. It could have been indigo carmine or some other solution. In this case, we in fact injected ICG. So on an ICG laparoscope, you can actually see clearly where the margin of the lesion is. And now you're doing a reverse CSD. So you're doing a serosal incision, and then you're actually exposing the underlying mucosal layer but not breaching the mucosal layer. So you can see that's the mucosa. So this is a reverse of an ESD. Well, fortunately, I had ESD experience, so this made me quite easy to do. And then you can actually transect the entire lesion now with a stapler and then close the serosal defect afterwards. So another technique that does not cause that contamination, but it's a really nice technique, especially for larger lesions that is partially exophytic. So I think it's difficult to compare both endoscopic and laparoscopic resection because they are basically treating different things. But generally, endoscopic resection is very safe, shorter procedural time, less time to soft diet. Complication rate are essentially similar, but endoscopic resection definitely would have a higher chance of margin positivity. It's very arguable what is meant by margin positivity and what's the implication to it. But nonetheless, for high-risk lesion, I would definitely recommend surgery over endoscopy. But for low-risk lesion, I do think endoscopy is the way to go. And in fact, this has been reflected in guidelines because in the ESMO guidelines, you can see from 2021 onwards, they actually recommended the possibility of endoscopic resection even for GIST. And this is, mind you, an oncology-targeted guideline. So even they are starting to realize the possibility of endoscopic treatment. And not to mention that the ESGE did put down wordings about the possibility of removing small GIST less than 2 centimeters as an alternative to surveillance, or to use an endoscopic resection technique over surgical resection for lesions that are smaller than 35 millimeter in size. So there are some algorithms that we published in the past. I do think you can go back and refer to which lesion would be better treated by different manners. And within the ANBIC group, we did also completed a consensus to look into different recommendations when we're talking about gastric GISTs. And hopefully we'll be publishing this very soon. And with that, I would like to conclude my talk. Thank you very much.
So is there any questions?
Hong Chi, I have a question.
Yes.
What do you think the advantages to doing a combined laparoscopic endoscopic resection in comparison to a pure laparoscopic procedure are?
Yeah, so that's an excellent question. So when you do purely laparoscopic resection, the problem is a lot of the time you're either doing a wedge resection by just a stapler. The wedge resection would end up resecting a very big normal mucosal margin. And in a setting where the lesion is located in the cardia or near the pylorus, then you might end up narrowing the lumen. Whereas in the lap endoscopic combined approach, you can actually see the lesion both intraluminally and extraluminally. Especially for lesions that are more intraluminal, then sometimes it's pretty difficult to find the exact margin from the outside. And in those cases, I do think a combined approach would help a lot.
I guess more of a comment, but I think that's exactly right, that depending on the location is so important, and I think that's where a combined discussion between an endoscopist and a surgeon and having that combined skill set is so integral to getting a great result.
Yeah, that's right. So I'm fortunate because I'm a surgeon and I'm an endoscopist, so I combine myself.
I think I agree. One thing about endoscopic resections is I think as endoscopic closure methods are improving and they're becoming more and more secure, I think majority of these endophytic lesions can be resected very safely endoscopically. Yes. Now, one of the still rate limiting or procedure limiting challenges that we face endoscopically is the size of the lesion.
Yes.
So larger lesions we can resect, but bringing them out of the G junction, we'll need to piecemeal marcellate them. Yes. And that's where for just you don't want to do that, because there's a risk of spillage. There's some work going on that, and probably too early to talk about that. And that is where we probably will need the lap endo approach as well, because that's how we can do that.
Well, I've heard some interesting approach by Chinese. Not I'm a Chinese, but in mainland China, what they do is they put it there and wait for the acid to melt it down before resecting it, before retrieving it. But I do not think that's a very good idea, because you're actually looking into the margin of a gist when you're taking out for histology, and I don't know what will happen to the pathological assessment when it was partially melted by gastric acid. So, yeah.
Right. With that, thanks, Hanchi.
Thank you.
That was great. Thank you.
Our next speaker is Associate Professor Gregor Brown, who is a physician gastroenterologist and head of endoscopy at the Alfred Hospital in Melbourne. He was previously chair of the Conjoint Committee for Certification of Training in GI Endoscopy, and now sits on the recertification in Colonoscopy Conjoint Committee, as well as the Clinical Advisory Group to the National Bowel Cancer Screening Program. He led the review of advances in colonoscopy chapter of the current Australian Surveillance Colonoscopy Guidelines, past chair of the Australian GI Endoscopy Association, remains active in the National Endoscopy Training Initiative. And as we keep moving down through from the esophagus and stomach, we're now going into the small bowel with a deep dive into the small bowel.
Thank you. That's great. Very kind. Thanks, Raj, for asking me. And yes, this is the first of three. Thanks for that. So I'm going to talk about the small bowel. We're going to leap the duodenum, because Dr. Yip's going to come back and talk about the duodenum in a moment. And I'm going to restrict myself mainly to small bowel bleeding, because that's what we do balloon enteroscopy for mainly in this country, and that's partly a funding problem. I'll talk about that briefly. I want to look at the different investigative options in the small bowel, a little bit about the Australian context, which I think does colour our approach, unfortunately, which is a funding issue, and then the current, just very briefly, a current approach to different scenarios. So we have got a whole lot of different options, and I'm really going to restrict myself again to radiology briefly and endoscopy, of course, because that's really what we're here for. This is my little thing about trying to contextualise all these different modalities that we have in terms of how good they are in terms of yield, and also how easy or quick or they are to do. And when the patient comes into the ED with bleeding, the first thing they sometimes get is a CT scan of the abdomen, because it's quick and easy, but it's completely useless, of course. And then we can move up, and really the CT angiogram, CTA, is a good test. The yield is not great, but it is quick and it's pretty easy. And I'm trying to contextualise those things, and you can see balloon enteroscopy, capsule endoscopy. The CT, I'm going to talk a bit about some of these specifically. I'm sure many of you will know all of this, but the CT angiogram is a great test because it is quick and it's cheap and it's available. You can get it done in the ED, and it seems to be done no matter what happens. Someone comes in with rectal bleeding and they get a CT angiogram sometimes. And when it's positive, it's fantastic. But one of the problems is it's often not positive because you have to be bleeding quite a bit at the time. In the context of the test to get a positive test. And it's, of course, the dye is nephrotoxic. So for many of our elderly patients who are not yet on dialysis but getting there, they're the ones who bleed and they're the ones you can't do this test on. And it is obviously diagnostic only, but certainly where I work, the different hospitals, the radiologist won't get out of bed to do an embolisation unless you've got a CT angiogram first. Even though you know exactly where they're bleeding from, for whatever reason that you do, they still won't get out of bed without a CTA. Whereas we'll get out of bed and do the scope. Capsule endoscopy obviously has been around for a long time now, over 20 years, over 25 years. And the great pro of capsule endoscopy, of course, is it gives us complete enteroscopy, which has been the holy grail of the small bowel for a long time. The yield of capsule endoscopy in general is high if it's done under the right circumstances. Obviously, if you do it for young female iron deficiency, you're going to get a low yield. But if you do it for people who are properly anaemic and or bleeding, the yield is high. And if it's negative in that context, it is quite reassuring. I think that's useful. The cons is it's relatively expensive. The capsule is costly, or at least it's not that costly, but it's expensive. They're different things, aren't they? It is relatively slow. By the time they swallow it, by the time they get the belt off, by the time it's uploaded, and by the time you look at it, we're looking at 2 or 3 days usually. The localisation in the small bowel on PillCam is dreadful. It's appalling, and all of us who do this know that you can so often get caught out by using time as an estimate of where things are, and that it's just inaccurate. And it is absolutely only diagnostic. Finally, well, not quite finally, balloon enteroscopy. So there's double and single balloons, as you probably know. Top right is a single balloon. The difference with the double balloon is there's a second balloon on the tip of the scope, and the concept is that the balloons gently grip the small bowel and allow deeper insertion in a cyclical fashion into the small bowel. But certainly in the Western context, complete enteroscopy with unidirectional balloon enteroscopy and even bidirectional balloon enteroscopy is low. We rarely get complete enteroscopy, unfortunately. Having said that, the yield, when used in the context of PillCam, which is often how we do it, usually you would do the PillCam, find something and then use that relatively inexact science to determine whether to go from above or below, is relatively high. And of course you have the availability of most of the therapies that we would have at routine interventional endoscopy, certainly for bleeding. So it's rarely complete is the con. It's moderately expensive. In Australia, certainly, we do generally use general anaesthesia for antegrade procedures, mainly for the risk of aspiration. And it's not widely available and it's not rapidly available. At the hospitals I work at, the public hospitals, it's not something we can do in the middle of the night. And one of the first things I say to the new registrars, as I said to them just the other day, is do not accept overnight the patient for urgent balloon enteroscopy, because we're not going to do it overnight when they ring you from the regional hospital. They can always wait. The scope is a long gastroscope, but there is now a flushing channel. But to date, neither scope has had routinely a flushing channel. And it's only when you get into the small bowel and get into a situation where it's bleeding like stick and you think, oh, I'll hit the foot pump, and there is no foot pump. Now, it's a real problem in a limited space. But we have got devices we can rig up through the suction channel where you can flush with a foot pump, and they work quite well, but it means you can't flush and suction at the same time. The other thing is that because it's such a long device, the working channel is relatively narrow. And once it's in deep with a couple of loops, things won't go through very well. So it's really hard to get balloons through, for instance, when you're in deep. And it also means it's very hard to get, if you're doing polypectomy, particularly Poitsiagas, which is, when you're removing multiple polyps, it's very hard to get tissue out because of the channel problems. I want to talk briefly about this boy, power spiral enteroscopy, which has come and gone, sadly. It was an amazing tool. It's very high yield. We could routinely expect to do complete enteroscopy, often unidirectional, extraordinary, relatively quick, excellent localisation, and the device is actually a paediatric colonoscope, so it had the capability to use any of the devices we're used to using and get them through really easily. The cons were the then limited availability, the need for GA, and of course the complications, which was why it disappeared. I just want to very quickly talk about an amazing case that just shows the power of this device when we had it, which was this man at my hospital who was bleeding repeatedly over the years. And in fact, we knew he had a Meckles. And I said to him, get your Meckles out. Have surgery, get the Meckles out. He said, no, I don't want my Meckles out. And in fact, it came to the fact that he ultimately had a pill cam which showed bleeding separate to the Meckles in the middle of the small bowel. And so we did a power spiral on this man, and why isn't it working, Raj? It's not working. Maybe we haven't got...
It's all right. It's okay. We can just get it off the... Where is it?
That one.
Okay.
Yeah. So this is an edited video of a procedure that took about... so that's the Polaris. So this machine, basically you press a pedal and the corkscrew turns and it just drives in. So it's amazing. The problem with it is that the flanges on this corkscrew are 30 millimetres apart, and so that 30 millimetres in diameter, so that causes problems in narrow places like esophaguses and sometimes small bowels, as I found out to my patient's peril. They both survived. But basically this is just showing you're pressing the pedal and it just goes in. It's amazing. For those of you who do balloon enteroscopy, this makes you weep because it's just so effortless. And basically, I might try, and so this is just going in, and then in a moment it'll cut to. So that's, I think there was a few minutes missed, and then this is the tattoo from the previous double balloon antegrade. I laugh at you, just go sailing past. And then here's the bleeding in the mid-small bowel. So this was a true, so you can just see bottom of the screen behind the fold. So I didn't want to treat that then, so I tattooed it so I could find it again on the way back. And that's the residual, that's the Meckles. So you can see the Meckles on the right, and we're heading off past the Meckles. And then this is something I've only ever seen once with a balloon enteroscope, which is from the mouth to the cecum. So that took about 20 minutes, 25 minutes, which again was unbelievable. So then we basically, I won't show, we came back and treated the bleeding. And that was in 2019 and never seen him since. He's been gone and he's still got his Meckles. So that was an amazing device. It had its problems. I had, in my own practice early in the day, 2 perforations. And one in the esophagus and one in the small bowel, and while both the patients survived, they had long hospital admissions, and it was pretty gnarly. And so it was withdrawn, not because of me, well, not only because of me, but there were complications around the world, and the manufacturer withdrew it in a couple of years ago, which is amazing. I've never seen that. Someone pull the device. They just literally said, no more overtubes, we're taking them back, you can't have it anymore. And I don't think we'll ever see it again. Just very briefly, the Australian context, for those of you who don't do this stuff, just in terms of referrals, capsule endoscopy has an item number, of course. It's relatively generous. The capsule costs about $800, $900. So it costs $900. It is only for overt GI bleeding or iron deficiency where celiac and menorrhagia has been excluded. They have to have had gastroscopy and colonoscopy before. You can do it up to twice a year, 12 months apart. You have to be CCRTG certified, so conjoint certified, but not in capsule endoscopy, in gastroscopy or whatever you like. It's a bit weird. And you can't do it on the same day as balloon enteroscopy. So I often get asked, can you just repeat the capsule with the balloon, put it in? You can't, because you don't get paid. And certainly in Victoria, where we don't do Medicare billing of inpatients, I don't know how other jurisdictions get away with it, but we can't do it on inpatients, at least in a funded way. Similarly, balloon enteroscopy has limitations because it is also only for recurrent persistent bleeding or anaemic or actively bleeding. So that just takes out Crohn's, non-anaemic Crohn's right from the start, which is a huge problem. Again, in the public hospital it doesn't matter because you don't get paid specifically, but in private you've got to be very careful because if you get audited, it's a lot of money to be paying back. They also have to have had a gastroscopy and colonoscopy prior, which is something a lot of referrers don't know. And they'll have done, someone will come in with anemia and they've had a scan and they've got a mid-small bowel lesion and they're elderly and they say, I don't want to do a colonoscopy, can we just do the balloon and get the tissue? And actually, in private you can't. Therapy includes a whole lot of stuff which makes sense, except for removal of foreign body. That's a bit weird. How does that relate to bleeding? The only way it relates is for the retained PillCam that I can think of. But it doesn't include stricture dilatation, which again is a problem for us, because increasingly we're being asked in the complex Crohn's patients who've had surgeries and don't want any more to do deep small bowel stricture dilatations, which we can do, but they're tricky and you don't get paid in private. So the current approach, very quickly, just before I finish. So there's two scenarios of bleeding. One is the subacute iron deficient anaemic we see all the time in the rooms, where they get the gastroscopy and the colonoscopy, and please don't forget to give them an iron infusion. It's really annoying when patients don't get iron infusions and they're iron deficient anaemic. And then most of the time we would do a capsule endoscopy to check the small bowel. About 25% of the time, less so now, about 20% of the time we find something within reach of the gastroscope or colonoscope, depending on where the referrals come from. And then we use the capsule very much to delineate whether patients need balloon enteroscopy and from which direction we should go. For the patients who are more acute hematochezia and anaemic, then certainly they're the ones who should get a CTA if it's otherwise safe to do so, because if you get an answer on the CTA, it just tells you what to do and where to go. But when that is negative, the gastroscopy, colonoscopy, and I think there is a role for capsule endoscopy in these patients, notwithstanding you may not get paid. We have a system at Alfred for doing in patients like this, depending how acute they are. The red cell scan is just not something I've done in years, occasionally. And then it's urgent balloon enteroscopy, and urgent is not overnight, but within a few days, if you can. Or on-table enteroscopy, I think that's very valid for some of these patients, particularly if you think it is a tumour that's bleeding. They're going to need surgery anyway, probably. I always think, and in talking with the surgeons I work with, they are very grateful if you can put a tattoo in at least somewhere up the top and somewhere down the bottom, so it limits the amount of bowel that has to be checked. And if you can localise it and tattoo it, that is gold, because then it's a laparoscopic procedure and less likely to be open, and the sort of hours of disastrous pulling bowel out and shoving scopes in and then in hospital for a week with ileus afterwards. So in summary, without Power Spiral, not much has changed in the last 15 or 20 years. It's PillCam, it's balloon enteroscopy and CT angiogram if they're bleeding acutely, and all of them are imperfect, and that's the problem that we face. Nothing is ideal. Thanks. If there's any questions. There was a video there, but it's not going to work. I'm sorry that there's a video, but it's not working. We haven't got time.
While we're waiting, Gregor, I'll just ask the question in practice. How hard do you try to get to a lesion in the mid-small bowel if you failed with your balloon enteroscopy before you ask a surgeon to to assist you with
It depends on the lesion, doesn't it? If you think it's a cancer or going to become a cancer, then we'll try a lot harder. But I think at the end of the day, if like I have access to both single and double balloon, I think from above they're pretty similar. I think if I'm really concerned, I would prefer to use a double balloon. I think you can get a bit further. Certainly retrograde you can usually. But if you've done a good antegrade double balloon and left a tattoo and you haven't got there, the pill cam or if you do a CT, I'm always disappointed in cross-sectional imaging in the small bowel for lesions we've seen on pill cam. You so rarely see them that I usually don't go there. But I will then say to the surgeon, well, I'll come and help you if you want me to come and stick the scope in, but have a look, and if they can find it laparoscopically, it's great. If not, I'm happy to help.
and I think you showed previously that the yield is much higher antegrade than retrograde. That was for single balloon, or was that?
The study we did with Andrew Taylor years ago showed the yields were pretty similar for single and double, actually, which I was surprised all of us. But that was the data. So, I mean, in the Caucasian context, I can't speak for Asia. The pathologies, AVMs are always in the jejunum. When someone tells me they've got an AVM in the ileum, I'm always suspicious because you so rarely see that. It's a jejunal phenomenon. I don't know why. Whereas stricturing disease tends to be distal and tumours tend to be, adenocarcinomas in the jejunum and non-adenocarcinoma lesions tend to be distal.
So push on more with antegrade before you...
I think sometimes you just got to give up and say too hard.
Yeah. Gregor, I got two questions. One is, how do you make out where the jejunum ends and the ileum begins on a single or double balloon? The second question is, what are your thoughts on AI in capsule endoscopy? Is that going to make capsule reading in 5 minutes and bring down the cost, perhaps?
So for the first question, I've got no idea. I can't even tell where the ligament of Treitz is. Right? Everyone says, it's the ligament of Treitz. So I've been past that ligament thousands of times and I don't know where it is. I've got no idea. And certainly, I mean, I don't think there is an anatomical difference. When I was at St Mark's, I was talking to Clive Bartram, who was the doyen radiologist at St Mark's at the time. He was actually also the head of the hospital. And he said, it's very easy on a barium swallow. You just follow it through and the folds do this and that. And I think actually you can tell on pill cam, the folds become more linear and you get a star-shaped contraction in the ileum. But endoscopically, that's not apparent to me. The second question, AI, look, it's going to come. I don't think we're quite there yet. I don't like them myself. I still use a manual... I mainly use Medtronic / Given, what used to be. I've played around with the others and I participated in a study with Rob Feller with the OMOM device. I think the problem is it only looks at the small bowel and we so often find pathology in the stomach or in the cecum and the colon and it just doesn't see it because it's not designed to. And it's like, well, and I said to them, well, what's that about? And they went, but it's a small bowel device. Well, that's crap. We use it, for everything. And if it doesn't see that stuff, it's wrong. But it's coming and it's going to get better and better. It will be there. Not there yet.
Thanks, Gregor. That was great.
Thank you, Gregor. After drowning in the small bowel, we're going to swim back up into the duodenum. We've got Honchi, who will talk to us about non-ampullary duodenal lesions, classification and treatment.
Sorry, Honchi, just a couple of minutes. Hopefully that's the right talk.
Nice. So I'll be talking about duodenal lesions, which is actually pretty uncommon, to be honest. So I wouldn't really say I'm an expert, but I'll try my best to discuss about this. Well, whenever you see something in the duodenum, again, there are actually a wide range of possibility from neoplastic to non-neoplastic pathologies. For example, you do see metaplastic foveolar epithelium or gastric heteropropia, especially in the duodenal bulbs. You will see sometimes inflammatory polyps or Brunner's gland hematomas. But of course, the focus of today would be talking about those epithelial tumors like adenomas. So we call them non-ampullary duodenal epithelial tumors, or sometimes subepithelial lesions are still possible, like GIST or neuroendocrine tumors. So focusing on these epithelial tumors, so we all know these are probably the precursor to a duodenal adenocarcinomas, although they are rarer than the other locations like the stomach, the colon, and in fact they were reported sporadically in autopsy studies in about 0.5% of them. And majority of these patients that we see with duodenal adenomas are those who are familial type, whereas the sporadic type probably is less common. However, it's interesting that we are actually seeing more and more sporadic duodenal adenomas, possibly because of our endoscopic quality, that now we're focusing a little bit more, we're deep diving a little bit more into the duodenum, and we do see abnormal lesions. So this study from Japan looked into different time period, and in fact when they compare the early days in 2007 to 2009 comparing to 2010 to 2012, they actually see a dramatic rise in the number of lesions detected. And overall, they detected majority of them were low-grade lesions, but they also see quite significant amount of even submucosal adenocarcinomas. So another important point to note is that the yield or the accuracy of preoperative or pre-resection biopsy comparing to the endoscopic assessment, in fact, was quite interesting. You can see that preoperative endoscopy had an even better accuracy than just taking a biopsy. So likely because you are just sampling a small part of a bigger lesion, which may end up having a sampling error as compared if you do a complete assessment of the entire lesion. So we do actually emphasize a lot on a detailed endoscopic assessment, not just to take a biopsy from whatever lesion we see, and to determine the need for subsequent treatment. And another study from Japan also pointed out that, in fact, if you do biopsy before doing an adequate assessment, if you come back and do an MBI or magnifying MBI, that actually would affect the results of your magnifying assessment, because the biopsy area would have some changes that led to an overdiagnosis. That means you now have poor interpretation of the exact lesion that may actually affect your decision to treatment. There are actually existing many classifications. Unfortunately, I don't think any of them are very popularly used, but I'll just mention some of them. So this is a non-magnified classification that tries to assess whether these lesions are low-grade or high-grade lesions, coming from Japan. And they look at lesion size, which is quite obvious. The reason is obvious. And the color, so it's been quite well documented that red lesions or erythematous lesions are those high-risk lesions, whereas whiter lesions are generally lower-grade lesions. And of course, macroscopic types with mixed depression or mixed morphology are the high-risk ones, and those with a heterogeneous nodularity are the high-risk lesions. And with that, you can calculate a score which may help you to predict the ultimate lesion invasiveness with reasonable accuracy. The other method is to use magnifying MBI or magnifying imaging. So you can actually see different magnifying features on narrowband imaging, including the open loop structures or the closed loop structures. And more often, lesions would signify a presence of a demarcation line. White opaque substance are actually described initially for gastric intestinal metaplasia, but in fact are very, very commonly seen even in duodenal adenomas. And similarly, like Buchrest, which is actually the typical appearance of intestinal type of mucosa. And finally, it's enlarged marginal crypt epitheliums. And in fact, if you add them together, you would see that some of them, comparing with non-neoplastic lesions, have quite high predictive values, especially for open loop structures, the presence of a demarcation line, or those with irregular microvascular or microsurface pattern. And this study actually proposed a so-called algorithm by looking into the open loop structure or a closed loop structure, followed by the presence or absence of white opaque substance or demarcation line as a sign to differentiate a adenoma versus a non-neoplastic lesion with reasonable accuracy. But again, I must say that it is not a very common practice to utilize all these classifications. But one thing is quite interesting and important is that nowadays we are more and more aware of the different phenotypes, even for these adenomas. So generally, we can subdivide these into gastric type, gastrointestinal type, or in the intestinal types. So earlier, you have heard the expert pathologist mentioning about the mucin staining. In fact, you can use the similar analogy of mucin staining even for duodenal adenomas or duodenal lesions. And those that exhibit more gastric type of mucin secretion would be the gastric type. Those that are exhibiting classical intestinal type of mucin, like MUA6 or 5, then those are more like the the intestinal type. And of course, there's a combined type in that. But what's important is that the gastric type, in fact, has a much higher tendency to harbor high-risk lesions. So you can see that in the gastric type in this particular study, although it's not a very big study, more than half of the gastric lesions are category 4-5 lesions, confirming to be carcinoma in about a third of them, whereas the intestinal type, actually only 3% of them were carcinomas. And that also translates to an endoscopic appearance because by location, you can predict which type it is. The gastric type most often comes from the duodenal bulb or the second portion, while the intestinal type majority comes from the second portion or beyond the major papilla of the duodenum. Of course, size might not differ a lot, but the presence of milk white mucosa or actually the white opaque substance actually predicts whether or not this will be an intestinal type or whether this is more likely to be a gastric type, because the white opaque substance is, in fact, most likely predict the intestinal type. And if you use a crystal violet chromoendoscopy, which I don't think many of us will do, but they actually could be able to differentiate some form of differentiality in terms of the microsurface pattern. For instance, here in photo D is the so-called pine cone appearance on the crystal violet chromoendoscopy, and this has a pretty high accuracy in predicting the gastric type, gastric subtype of duodenal adenomas. So this is even more complex, which I'm sure nobody is using at this point. Reported back in 2014, using NBI structural pattern, surface and vascular pattern to try to predict the ultimate pathology. Well, personally, I don't even really use them very often because of the complexity of using it. But this is one thing that you can consider, because predicting using the NBI, you do see different morphology on a magnified images. So ultimately, I think what we try to do is we differentiate neoplastic from non-neoplastic lesions. I think it could be confidently performed, but to differentiate low-grade versus high-grade lesion, it could be more difficult, but ultimately size is a significant factor. Red in color or depression or heterogeneous lesions are those we have to bear in mind that they might harbor high-risk lesions. Then it comes to the second part, which is the treatment. So generally speaking, I think there's no doubt that we should resect at least all of them, if, especially if they are sporadic cases, because of the malignant potential. So there are methods that we can do, similar to what we do for our colonic polyps. For smaller ones, in fact, I think cold snare polypectomy are the majority, the main option that we can choose. For lesions that are between 10, 20 millimeters, then the EMR technique would be definitely very useful, while those that are larger would be the most controversial type, because you can have different options ranging from a en-bloc ESD versus a piecemeal EMR or even surgical options. So cold snare polypectomy, I don't think I need to elaborate too much. It's a very useful technique for small GI polyps. In this particular early study, and the en-bloc resection rate was very high and low recurrence rate for small lesions that are less than 6 millimeters in size. In fact, to extend this kind of cold snare polypectomy, there has been some study that showing that even for familial type, for example, those with FAP, an intensive downstaging polypectomy by using cold snare polypectomy could in fact induce a significant downgrading of the Spigelman grading or staging of patients who suffer from duodenal adenomas from FAP. So this is a very useful technique for small lesions. For larger lesions, then we do have issues. So this actually comes from Professor Arnold's group back in 2011, where they look into the complication rates of EMR versus ESD in the duodenum from 13 hospitals in Japan. So those are already expert centers. And at that time, you see a alarming number of perforations, 19% with ESD. And even more alarming is the 6.0% rate of delayed hemorrhage, a delayed perforation. So these are actually very difficult to manage when patients do present with such complication. So at that point, the consideration is quite different from esophagus, stomach, colon. And the duodenum, from the safety point of view at that time, I think more and more people are emphasizing the use of EMR than ESD, much more than in the stomach or the colon. And what actually revolutionized a lot in terms of the management of the smaller but not so small polyps would be the underwater procedures, which is proposed by Professor Ken Bimella back in 2012. So underwater, the muscle stays at the periphery, but the mucosa floats around. That gives you the window for achieving a en-bloc resection, even for larger lesions up to 20 or even sometimes 30 millimeters in size, with a safe, very high safety profile of very low perforation risk. So this is a video showing how this can be done. You can see after putting it underwater, basically the lesion is floating, so similar to what you do in the colon, and then you can safely graft the entire lesion and perform an en-bloc resection even for slightly larger lesions. So the advantage is obvious. It's much more easy to capture mucosa instead of injecting it and expanding the lesion. And with the submucosal buoyancy, the lesion would appear much more softer and protruded. And it actually also make it easier to close, because you did not inject, the lesion size or the defect size would become small. And if you need to close it, it's actually quite easy. If you compare it to ESD, then obviously it's still difficult to achieve the same degree of en-bloc resection. This is one of the studies published from my mentor, Noria, where they look into the duodenal underwater EMR over 21 institutions for lesions less than 20 millimeter in size. And what they finally recruited is 140 patients with 151 adenomas, and they show that the en-bloc complete resection rate was actually 97%. And there was only 4 patients with recurrence out of these patients, and all of them were actually treated by a repeated endoscopic procedure, and none of these patients required surgery. And you can see the safety profile as compared to what we've seen just now is much more safer with a low intraprocedural or delayed complication rate. And in the longer term, they actually published the data and show that the 3-year recurrence rate was 25%, a little bit higher than expected, but all of them were managed by endoscopy. So none of these patients ultimately develop a cancer or a recurrence that requires surgical salvage. So indicating that the underwater technique is still very safe as compared to the ESD technique. And they recently published another technique which is called the tip-in underwater EMR. So instead of just putting the snare, this time they actually inject and open up the mucosa slightly, which allows you to put the tip of the snare over that region. And this actually helps to stabilize the snare to perform a slightly more stable endoscopic resection and encasing a lesion even larger like this. And the publication actually showed a higher alveolar resection rate compared to the conventional underwater EMR technique. So finally, some small words about duodenal ESD. I know there's a long debate tomorrow about colon ESD and EMR. For duodenal ESD, I think it's even more difficult to attempt. Although there has been some methods that have been proposed that could improve the resection safety, such as the water pressure method and closure of the mucosal defects afterwards, which actually help to achieve a much lower delayed perforation rate. And there are some techniques of closing defects, such as the Rollum technique proposed by Dr. Nomura from Japan, by using a number of clips along the line to close the entire defects. Because of time, I would not show the videos, but underwater procedure is actually definitely making these ESD much safer. But still, it's technically super demanding, and I wouldn't attempt lightly unless lesions are really of high risk of malignancy and you do want an en-bloc resection. And if you look into outcome from Japan, they actually showed reasonable en-bloc resection rate, quite high with the ESD compared to non-ESD. But with time, you notice that the delay adverse event rate actually became lower compared to the initial publication by Arnold's group. And interestingly, they actually show that the en-bloc resection obviously is directly relating to the size, but adverse event is also equally directly related to the size. And in fact, non-ESD techniques also had a very high adverse event rate, even when compared to ESD group, when size are much larger. So this is something we need to bear in mind. But so I would like to conclude that I think for colonic, for duodenal adenomas, generally speaking, I think underwater EMR or cold snares are the most safe and efficacious methods for smaller lesions. And in general practice, for larger lesions, when high-risk lesions, then it might be considered to perform ESD, but definitely you need the expertise like Raj or Niroshan here that might be able to help you to perform some of these difficult procedures. So thank you very much.
We've got a question from the Slido.
So what's a safe number of sub 6 millimeter polyps that can be removed in one session?
Sorry?
What's the safe number of sub 6
I don't think there
polyps?
is actually a limit. So if you look into the data from Japan, I think they actually remove a median of 50 or something polyps for those patients with FAP. I don't think there is an upper limit. As long as you're continuing, but you're not causing any complications. Generally, cold snare, you hardly see any complications. Yeah.
Sanchi, a couple of questions, if I may. One is that, what is the reported perforation rates with underwater EMR in the duodenum, and how dangerous that is? That's the first question. And I guess the second question is, with all hot EMR or ESDs in the small bowel, it's best to close the defect.
Yeah, so for the first question, I think from the literature, the delayed or intraoperative perforation rate for underwater techniques in the duodenum is quite low. So it's probably in the range of 1 or 2% only. So you remember what Ken Bimela often quote is the muscle layer stays outside. So if you just catch the floating mucosa, generally speaking, it's very hard to catch the muscle unless you're very, very aggressive in terms of getting the mucosa. But you're also right that generally speaking, we would prefer to close defects after duodenal resections, be it ESD or EMR, especially for lesions that are beyond the duodenal papilla, because the pancreatic secretion and the biliary secretions are actually quite detrimental to the wound, and any small burning of the muscle could end up with a delayed perforation if it's not adequately closed. So that's the general recommendation.
Maybe a couple of words on neuroendocrine tumors in the duodenum. And what are your thoughts on that?
Yeah, so for neuroendocrine tumors, I think it's somewhat different. So usually you can get a biopsy and you will confirm it. And these lesions are actually seated quite deeply in the submucosal and even sometimes on the surface of the muscle. So I think Amol has a quite good experience on it. But more often you will need to do a deep resection. So case selection is important. So you need to anticipate that you need to resect deeper. So for lesions that are larger than 1 centimeter, you really need to think twice, because most of these larger than 1 centimeter neuroendocrine tumor might harbor malignancy, and then they might be better treated by surgery. But less than 1 centimeter, I think there are good cases for endoscopic resection. There are different school of thoughts. Some would do a band-assisted EMR and try to get deep as possible. But I'm still a little worried about the deep margin in these cases. So a freehand resection, but going slightly deeper or even shaving off the muscle could be done. But mind you that you will need to close the defect definitely afterwards. So I guess Amol can supplement a little bit on this.
I think regarding the neuroendocrine tumors, definitely, larger the lesion, more chances that it may be adherent to the muscle, even if not involving. But we have to shave it off from the muscle. Now, unlike what you said, meaning 10 millimeters is too small, but probably even up to 2 centimeters, we can get these lesions out with just an ESD or a little bit of muscle shaving. But and you'll very often get a deep margin also clear. But anything larger than that, you may need a full thickness resection. But definitely these need closure. The other point which I wanted to just highlight on in one of your slides, that you mentioned that the size determines the adverse event profile of these lesions, and that's, I think, related to the secure closure, whether a secure closure can be done or not. Because as you rightly mentioned, all lesions beyond the duodenal papilla, we need to close those lesions, those defects. And the larger the defect, is more and more difficult to close, because duodenum being an angulated structure, it's very difficult to get all those closure devices inside, and it can really get very challenging. And it's just not delayed perforation, but delayed bleeding as well. So that's again a challenge. That's how it is. Right.
Thanks, Hanshi. Thank you very much.
Thank you.
We have a couple of Slido questions which we'll try to answer if we can. We'll just go to the last talk now, if that's all right, and Amol will be presenting it off his laptop.
Sorry about this. Yeah.
Sorry, it's okay.
Last talk, a state-of-the-art lecture by Amol Bapai on adverse events in upper GI, why they occur and what can we do.
Well, when thanks Raj again. When you're given the state-of-the-art talk, you know that you're probably, between the end of the session and lunch or dinner or something, and then you're just obstructing the field, that kind of a thing. And also, the other thing is, when the topic given to you is something as, as interesting and as complex as Raj decided to give that to me, adverse events in upper GI endoscopy, and he wanted me to cover the entire spectrum of it, I said, wow, that's something, meaning I'd never thought about this topic and what. But as I went on with this, there are quite a few interesting thoughts that I've put together. Let's see what you think about it. Why they occur and what we can do. So some disclosures, no financial disclosures, fortunately, but a confession, my only claim to fame to be standing here to give this talk is probably that I admit that I have possibly encountered, been involved in some way of interest, or treated every adverse event that has been discussed in this thing. And my only conflict of interest here, that I may not have been able to use my best judgment every time that I have treated these patients. At least in some situations, I'm sure I could have done better. So why do adverse events matter? See, upper GI endoscopy in general, it's a very low-risk procedure, practically a no-risk procedure. And, that's how we counsel our patients. And when something goes wrong, it's really very difficult for patients to understand why that happens. But at the same time, endoscopy has not remained the same in these last 70 years. Our patients are getting more elderly, more frail. Most of them are on antithrombotics. And we are doing more and more of therapeutic and advanced interventional work. And also, quality benchmarks are now adverse event-centric rather than just completion-centric. And we have to remember that adverse events are not just accidents, but they are very often system outcomes. The entire system, we need to look at that. So how do we define an adverse event? It's an unintended harm related to the procedure, sedation, or a peri-procedural care. And these are the categories: sedation-related, mechanical or procedural, thermal, electrosurgical, infective, or delayed post-procedure events. And the severity grading, we had the ASG lexicon, we have the Clavian Dendo, and then the AGRI classification, which I will touch on that. But mild, moderate, severe, that is basically based on whether intervention is required or not, or whether hospitalization is required or not. The AGRI classification is probably the latest, and that is something that I think all of us should be aware of, that grade 1, 2, and 3, these are the patients, and this is how we classify these complications. So, how common are adverse events after upper GI endoscopy? So after a diagnostic endoscopy, it's very low, 0.1 to 0.5. After a therapeutic upper GI endoscopy, is around 2 to 10%. Advanced endoscopy, particularly resections, 10 to 20%. And there is a less than 0.101% mortality, which is mostly sedation related rather than the procedure related, if we to put all of that together. So that's how it is. So when we look at why adverse events occur, we can have patient factors, sedation related, we can have procedure related, or the operator and system related. And let's touch upon these one by one. So patient related factors, elderly age, ASA grade, comorbidities, cardiopulmonary disease, liver disease, kidney disease, all these, and altered anatomy. Most of these are important risk factors, and most of these are underestimated when we are actually planning these patients for an endoscopy. Very often a patient with a cardiac disease will walk in and he or she is scheduled for an endoscopy, but probably not that much importance is given to the cardiac status as it probably is required. Why do sedation-related adverse events occur? Particularly hypoventilation, more and more of our endoscopies are happening under propofol. And there is a loss of airway reflex and aspiration. So patients who have a high risk of aspiration, we'll come to that in some time. But aspiration is a major risk, and that can cause hemodynamical instability as well. And what are the high-risk situations? Obesity or patients with an OSA, emergency endoscopies, patients with bleeds, or a prolonged endoscopic procedure like an ESD or a POEM can probably lead to sedation-related problems. Procedure-related, like mechanical trauma, like because of the scope or over-tube, barotrauma due to over-insufflation, thermal injury, and deep mural injury. And operator or system factors are inadequate training or credentialing, fatigue, time pressures, poor communication between the nurse or the technician and the endoscopist, and lack of SOPs, also absence of post-procedural surveillance, which we'll touch upon. So how do we perform a risk stratification and an anticipatory risk stratification even before the endoscopy is performed? So we assess the sedation risk and stratify this risk according to the low, intermediate, or high risk. So diagnostic endoscopy and a patient with a ASA 1 or 2 grade is low risk. The same thing for a therapeutic endoscopy, it immediately becomes an intermediate risk, and a prolonged endoscopy in a high risk ASA category patient is a high risk. And then of course we have bleeding prevention and response algorithms that we need. Before the procedure, we need to plan the endothrombotics very well. Intra-procedural, early hemostasis is important, and post-procedural, we need to observe these patients carefully and give them the appropriate instructions. And perforation, how do we manage that? Red flags, pain, endoscopic closure and escalation, immediate recognition, that is important. What is most important to understand that whenever we plan an endoscopy, many of our adverse events are going to be foreseeable at the time of scope insertion. So let us be mindful about these things. Aspiration, the silent catastrophe. Why is it underestimated? It is basically because it's often unwitnessed. The symptoms are delayed. The patient may start even a few hours later, and very often it is misattributed to a pneumonia or sepsis later on. But the event occurred at the time of the endoscopy. Let's remember that. And what are the high-risk situations? Patients with an upper GI bleed, and we all know that the commonest and the most common reason for mortality after an endoscopy for an upper GI bleed is not bleeding itself, but it's aspiration pneumonia. Gastric outlet obstruction and a stomach which has not been decompressed prior to endoscopy, a poor fasting status, patients in an encephalopathy or alcohol abuse. And in these patients, what is important is we need to protect the airway prophylactically. Intubating the patient is not a failure. Let's remember that. It is a protection. It's in the interest of the patient. It is just risk management and better judgment. That's very important. Bleeding. Coming to bleeding. How can we anticipate bleed? So patients with portal hypertension, they have pressure-driven bleeding. The mucosa is fragile. They have high rebleeding risk. And cautery can worsen injury in these patients. The rule is to control the pressure, not just the bleeding. Whereas in non-portal hypertension bleeds, the bleeds are very often lesion-driven. There may be a bleeding ulcer, or there may be a dulophosis, or we may be performing an EMR and ESD where that field is bleeding from. And field control in these patients is very critical. So it's different when we are treating portal hypertensives versus non-hypertensives. Excess thermal use further can increase the risk of perforation, whereas you may be able to stop the bleeding, but you may land up in a perforation later. So if the common errors are that attempting hemostasis without proper visualization can be risky, and repeated diathermy on the same site can be detrimental, and that can be more dangerous. So we have a visible, clot like this, an adherent clot in a visible vessel. And let's have a, probably just a show of hands in the audience. How many of y'all would do a cold snare? And are we ready for this? Because this, it's been recommended that most of us, that we have to perform a cold snare, look for an underlying vessel, and then perform the endotherapy. But whenever we want to perform a cold snare in this kind of a situation to remove the clot, are we ready with all the clips, with all the armamentarium, with the hemospray? Because once you remove this clot, you may end up with a spurting vessel, and then if we try and hunt for a clip or hemospray, that's going to be detrimental. That's how it is going to be. Coming to hemospray, I think that is one of the most wonderful things that has come up for most endoscopic procedures, for bleeding, and it really salvages the situation. Now you can see, even despite after putting clips on the left-hand side, there was some oozing, and this ulcer on the right-hand side, I don't know whether you had a look at it before we started spraying, is a huge ulcer. You just can't put a clip out there. So you just have to spray this and put these patients on medications and other things and make sure that they don't bleed again. So any attempt at stopping the bleed in this situation can be more risky. Again, for ulcer bleeds, which clips? Over the scope or through the scope clips, there is significant evidence now that OTSC are superior to through the scope clips for hemostasis, for primary hemostasis. However, the TTS clips are much easier to apply, and OTSC probably you need more expertise and you need more experience with those clips. Just post-EVL bleeds, we need to remember that advanced liver disease, high MELD scores are the risk factors. And anticipating this rather than allowing it to happen is the best way. If it occurs, of course, cyanoacrylate injection into the feeder is one of the best salvages, and adjuvant pharmacotherapy is crucial, and supportive measures are mandatory. During resection procedures or third phase procedures, now this is how. Just simple measures, how we stop bleeding with a tamponade with a cap, just keeping on injecting and irrigating. Or on the other side, we can see over here, when we are performing a myotomy, we have to be mindful that the vessel is horizontal, transverse, and it bleeds from both sides. So we have to coagulate on both sides, not just one side, and that helps. Wherever we are coagulating, it's also important not to miss out on thermal injury. And that is basically because most of us and most of our endoscopic accessories are they are monopolar instruments. They are not bipolar. Very few instruments are bipolar. And because of that, there can be a significant lateral thermal spread, deep mural injury without any immediate signs, and then we can have a delayed necrosis of perforation. This is typically what happens and what Hanchi demonstrated in the, discussed in the duodenal ESDs and EMRs. And what are the high-risk situations? Thin-walled esophagus, fibrotic submucosa, repeated coagulation at the same site, and applying cautery after you've applied a clip on a bleeding site. So if we want to use a mechanical device, then there is no way we can apply a cautery after putting a clip out there, because the clip will just transmit the current deeper and you will have a full thickness perforation out there. So if we need repeated cautery, we are already in danger territory. Gas-related adverse events, again, we are seeing this more and more commonly, because although we are using CO2 more commonly in our therapeutic endoscopic procedures, I think many diagnostic procedures may still be performed under air. CO2 is definitely safer than air, but it's not 100%. What are the consequences? It can lead to barotrauma. You can see this is a poem which was being performed, and over insufflation, it can cause striae marks in the stomach with some submucosal bleeds. And which are the high-risk situations? Tight strictures, prolonged upper GI procedures, especially APC. Because APC, apart from the insufflation that we are doing, APC also pumps in a lot of argon gas, and which does not get absorbed very easily. Post-surgical anatomy, again, is a major, we have to be mindful about these things. And CO2 is a safety tool, but it's not a luxury. We must use CO2 all the while. Touching upon infections, so rare infections, but rare, but they are real, particularly after PEG, or there can be bacteremia in patients with prosthetic valves and other places. And very often, infections do demonstrate scope reprocessing failures rather than anything else. Coming to perforation, because I think there is some part in this that I would like to discuss. Diagnostic endoscopy is a high-impact procedure, and the frequency of perforation is really very low. But esophageal perforations can occur during dilatation, during foreign body removal, or while traversing a stricture. What are the red flags? Severe pain, or a subcutaneous emphysema, or unexplained tachycardia. And how do we prevent a perforation? These are the non-negotiables. Never push against resistance. Fluoroscopy, use fluoroscopy whenever needed, use guide wires, a gradual dilatation strategy, and an early endoscopic closure mindset. Perforations do not happen suddenly. They're usually preceded by warning signs. Pain during an endoscopy is never normal. It will always be mindful that you should suspect a perforation. And whenever, if we want to prevent a perforation, the only single cardinal rule is back off. Avoid the urge to complete the procedure regardless, because that is the single most important factor that can increase damage. That is most important. Timings determine outcomes when we are talking about perforations, and early recognition allows endoscopic closure, avoids surgery and mortality. And late recognition can lead to further problems. How do we treat perforations? Well, we have a whole lot of things, depending on whether we detect them early or late, and some detection about early points. So typically through the scope clips can be used, typically for small defects when opposition of edges is possible, when we have to use the widest clips possible. So this is not a treatise on closure devices. I think Niroshan is going to cover this. But this is a duodenal perforation which occurred during a side wing endoscopy, actually a duodenoscopy, but then we just shifted over to a upper GI. But what is important to remember is use a cap, because using a cap you can apply the clips much more effectively, and you can use the suction more effectively, avoid tension on edges. A linear defect like this, now this occurred during a resection procedure. You can see this while retrieving the specimen after an EFTR, and this is how we can use a zipper closure to actually close the defects. We can use full thickness clips as well, and there are several that are available in the market, and they're quite easy to use. Actually, the mechanism is very similar to the EVL mechanism where we can use a tripwire. The only thing is, it's a one-stop thing. Once you fire, it's very difficult to, you can't come back, so you have to be very sure that you are firing it in the right place. But you can use graspers, you can use several device suction, and then you can use this thing. And it gives you a very secure closure for defects up to 2 to 3 centimeters. These are some comparisons when we're talking about closure techniques, clips versus all the other techniques. And I'm not touching upon the other aspects because this is not the topic of our talk. Delayed and missed adverse events, a word about this. Delayed bleeding, post-procedure pain, missed perforations and missed cancers, which is again a quality adverse event. The key issue is, just because the patient is discharged does not mean that our responsibility ends. We need to follow these patients up beyond discharge. A word about how do we break the news to the patient and the family. Why does it matter? Poor communication worsens outcomes, and silence creates mistrust. Delay escalates the medico-legal risk, and that has been shown. And what do our patients remember? If, when, and how they were informed. They do remember when they were informed and how they were informed. If their queries and concerns were addressed and responded to seriously, that is another thing that patients' family members definitely do remember. Whether the team remained on site and whether they demonstrated ownership and coordination amongst themselves while handling the situation, that is what they remember. And therefore, these are the principles that we should follow. Prompt, honest disclosure of the event, acknowledge the uncertainty which led to that event. At the same time, we focus, inform, and document facts, decisions, and discussions. We need to remain assertive, confident, yet we need to demonstrate empathy. We must avoid defensive or minimizing language. We need to involve our colleagues, intra-departmental as well as other specialties, while planning the action, and discuss and inform about the proposed action plan. And we need to take ownership, responsibility, yet may need to maintain our composure at all times. How we communicate very often decides the outcome of how the patients are going to react to the adverse event rather than what happens. The last part of the talk is about why they occur. Let's look at the systems. So cognitive biases that drive adverse events. These are the common traps. Normalization of deviance. This always happens in my patients. Oh, this is normal. This always happens. Why do we do that? And that leads to adverse events. Outcomes bias. The patient was fine the last time I did this procedure. I did an AVL banding last time. Patient was fine. This time, it can go wrong. No, we cannot decide that. Authority gradient. The team hesitates to speak up. Our team members, we are not guards. As endoscopists, we are not guards. So we need to be told by our juniors sometimes. And time pressure, I think we all know a lot about that. Most adverse events will involve at least one cognitive bias over here. Some operator-related factors, the hard truths are that fatigue. I think we all get fatigue at the end of the day, and we are not heroes where we can work those 12 hours and 16 hours. Overconfidence, volume without reflection. So we might be doing, and that is a typical problem very often back in India, where, numbers are all that matter very often. You guys probably deal with lesser numbers, but that's something that we need to think. And the other thing, the last important thing is poor complication ownership. What we have to remember is experience without an audit about these operator-related factors is dangerous, not for us probably, but for our patients. What is the role of the endoscopy team? Our team is not us singularly. Our nurses, our technicians, even the assistants within the room, our fellows, all of them are useful. And there should be a clear escalation pathway. It is well documented that nurses detect deterioration earlier than monitors. That's how it is. And psychological safety enables us. So there has to be a senior leadership role, and this has to happen in our intra-departmental meetings, where a decision has to be taken, and this is something that we do very often, and this is, for the last 25 years in our unit. Every endoscopy technician is empowered to pull out the scope or pull the scope from the endoscopist's hand if the technician feels that it is risky for the patient. And this is something which I have ensured in the unit. Of course, it still does not happen, half the times, but yes, but they are empowered to do that. And okay, anybody will fight, we will sort that matter out later on, but the patient is important. But it's important that juniors and our techs interrupt us and show us the correct path when we are deviating. Very often we are focused on the resection. We're doing an ESD, we are too focused on the resection, and we lose track of this thing. Underreported adverse events. Why are they underreported? There is a fear of blame, naturally so, and there is a fear of litigation. There is a lack of structured adverse event definitions. That also is there. I think hopefully with the AGRI classification now we are better evolved in that. And there is an absence of a unit level audit culture. But we have to remember that units which report more adverse events often have better outcomes of the adverse events. So we may have more adverse. It's not wrong to have an adverse event. It may still occur, but it's true. And to prevent adverse events from happening, I think we again have to go back to the checklist manifesto. We need checklists. So a typical pre-procedure checklist would be an indication and consent, an ASA and airway risk assessment, antithrombotic plan assessment and documentation, and equipment and CO2 availability that needs to be checked. Then, of course, the timeout, and I don't know how many of us do a timeout for a simple upper GI, but I think it's important, and that's how. And also the post-procedure, so team briefing, clarifying the role of every individual within the room. The sedation plan has to be verbalized. Recovery monitoring has to be completed, and clear discharge instructions have to be documented as well as verbalized both. We definitely need an adverse event audit template, and this is just a guideline where patient factors, procedure type, sedation, and this is going to be. These are some red flags. And whenever we have more than 2 red flags, we need to escalate monitoring and staffing within the room. And discharge red flags, even if there is one, re-evaluate, assess, monitor, and do not discharge. In their mortality and morbidity reviews improve efficiency, let's remember that. Reviews prevent system failures. Some future directions, AI-based prediction models may improve this, and there can be simulation-based as well. And we can have definitely more nationwide registries and shift from volume-based to value-based metrics. But knowing to stop is probably the most advanced skill, and this is something which probably these last two slides are about my personal experience. We need to look for warning signals, rising sedation requirement, physiological drift of tachycardia, resaturation, increasing pain, and that's how it is. Aborting a procedure is not a failure, it is a judgment. And how my practice has changed with practice. Experience matters, but reflection and introspection matters much more. I nowadays will have a lower threshold to stop, earlier threshold to allow airway protection. And whenever we are dealing with frail patients, we need to look into all these aspects. So few key takeaways. Adverse events are predictable and often preventable. Stratification and classification is desirable and necessary. Sedation is one of the most common risks. Bleeding and perforation, early detection and prompt management is the key. Prevention and early recognition is the most important than rescue. Safety culture, systems, checklists, audits are the cornerstones of prevention. As endoscopists, we are empowered to a great power to be able to perform all these procedures. But as it is always said in Spider-Man, with great power comes great responsibility. And we need to perform our endoscopies more responsibly. Thank you so much.
Thank you for a great session to all of our speakers. I'd just like to open the floor, not just to questions from our last talk, but any of the other speakers throughout the session.
So we have a question from Slido. Gerald, you want to?
Yeah, actually this is directed to Honji. So what are your tips and tricks for improving underwater EMR in the duodenum? And so may I also add on, and how deep will you go to even attempt an underwater resection in the duodenum?
So I guess in general, the underwater EMR technique in the duodenum is more or less similar to that in the colon. So the tricks applies in both. Number one is you need to make sure the entire lumen is filled with saline or sometimes water. And the way to do it, I think, is first of all, you need to aspirate all the gas. So in the duodenum setting, then you probably should even aspirate the stomach as well, because the more water you infuse, that means if the stomach is still filled with gas, the gas will come down or come up, and there's a risk of aspiration, obviously. So decompress as much as possible, and then start infusing saline water. And then you observe the lumen until the extent that you can see the lesion, but you're not overly distending it. Try to put the lesion at as much as possible on the 6 o'clock or 7 o'clock where the snare is positioned. And then you try to position your scope slightly beyond the lesion. You can still see just proximal. You can use a cap to help you to press down the lesion. And you go just slightly beyond it, and then you angle down, and then you start opening up your snare. And once you open the snare, you pull back the scope gradually, smoothly, and then you, at the same time, angle down so that you're actually pressing onto the lesion by the snare. And at that point, there will be a sweet spot where the snare just nicely encircles the lesion that is floating on top. And then that's a good timing when you close the snare. And after closing it, you can actually insufflate gas or not. It doesn't matter. And then you can activate. Usually, my own preference is to use more cutting current than coagulation current to avoid too much of burning underneath. And then you can stop the bleeding afterwards. So that would be my trick. I don't think there's a definite deep or the depth that you cannot do underwater EMR, but you will know that if you use a gastroscope, you probably can only get maximally to D3, and you start getting looping and you cannot get any deeper. So one thing you can consider doing is to use a pediatric colonoscope. with a better down angle, then you might be able to reach deeper and also get slightly better catch of the lesion. So that's some of the tips.
Okay, thank you.
Thanks. I think on that note, with that excellent lecture, Amol, thank you very much. We'll need to borrow some of your slides so we can brief people tomorrow on some of the key takeaways which you have given us.
Definitely.
So thank you very much, Amol.
Thank you so much.
That's something which you should not drink tonight to prevent an adverse.
No, I have a talk tomorrow which I still.
Thank you. Thank you very much. Can I invite Liz Murphy to hand this to Honchi? Thank you, Honchi. So Liz is the Divisional Director of Surgery and will tell us all about proctology tomorrow. Thank you. Thanks. And if it's okay, can I ask Heath to come out? So Heath's my co-chair, and we'll just hand over some of this to Raghu, Krish Raghunath, Professor Raghunath. Thank you. Dr. George, he doesn't take alcohol, but he could start tonight. Professor Brown, Gregor. And Tony, who does liver transplants. and finally, Derek. Thank you. So we'll meet again tomorrow. So it's an 8:30 start, if I'm not mistaken. And there's the whole colonic session tomorrow. So for some of you who've got your badges, please bring them along because we can't print a new set of badges, I guess. But there'll be, I think, a full house tomorrow, given it's a Saturday and people tend not to work too much. So thank you all for coming today, and we'll see you guys in 15 hours' time. Thanks.